Hello, a very good day to all my friends out there. Is my voice audible and clear to all of you out there? Hello, Dr. Sujata. Hi, Harshaba. Hello, Abir. Hi, Dr. Sabia. How's everybody doing? Am I audible to all of you? Thank you very much. Hi, Dipti. Hello, Dua. Hi, Liana. Hello, all of you. I hope people are joining in. Few had their presentation in the beginning. Thank you very much for the thumbs up. Thank you, Harshaba. Thank you, Dipti. A very warm welcome to yet another discussion. We started our journey with sexual and reproductive health. It's been long, but today we are going to have a good discussion on subfertility. Walaikum assalam, Liana. Thank you very much for joining in. And then we are going to proceed for gynecological oncology as the last live session discussion. Though we have to cover a lot, we are going to do certain other topics on the books practice as well. But for the live sessions, this is the second last session for today. That is the subfertility. Now, we had a little up and down in the presentation sequence today, friends. Girija is traveling today, so nobody was ready to exchange. I did request that Liana is going to do that, but if she would be doing two stations, one for her, Shiba, and one for Liana, for Girija herself. So let's discuss that, how the things would be. And then we've got Divya, we've got Sarvat, we've got Dr. Sujata today, and Liana for Harshaba, Dr. Sujata for Jyoti, and Dr. Sabiha is going to do the station, and then one station is with Dua. So Liana, before we begin, do you have got the station in the oncology, right? Yeah?
Yes, ma'am. I have one more station.
I understand. And today, are you doing Harshaba's station, or was it an initial exchange?
It's initial exchange. Hashiba did mine previously.
That's perfect. So that means that you can do two, right? If you agree. That
Yes,
today
ma'am.
you're doing Harshaba's because that was an old exchange, and Girija can do your next, yeah?
Yes, ma'am.
Are you comfortable doing two stations, or would you like one from oncology?
I don't mind, ma'am.
Okay, that's perfect. All right. So, Girija, whenever you listen to the recording, the last station for Liana, you're going to do in oncology. Okay. Thank you very much. All right. So that means that we are going to start with Liana today because Girija was number one in the presentation. All right. So be a quick reader, all of you. Up till now, you all know that we have to be fast reader. We have to read each word very carefully, and 1 minute for please organizing yourself. Regarding subfertility, if you do three to four topics, like the male subfertility, it comes every time in at least 1 to 2 days out of 4 days. We've got tubal subfertility, we've got complication of ovarian hyperstimulation syndrome, certain rules and regulation of same-sex partners, though it didn't come in exam, but it did come in many mock exams in UK. So it's an important station. Single parenthood is one station in Lisa Joel. Surrogacy, you should be knowing about the rules and regulations which are followed for the surrogacy. And male subfertility, I'm going to provide you an algorithm today. In all directions, in all aspects, male subfertility should be very clear to all of you. Interpretation of semen analysis is very important because you pick up the pathology and the problem in the semen analysis, and then you're going to diagnose the condition with the background of history. Unexplained subfertility again is very important. Sterilization, reversal, regret is a very important station. We're going to touch one today. Polycystic ovarian syndrome can come as a structured discussion. It also comes as a simulated patient task. Please keep a note. And WHO ovulation disorders, I would like you all to go through the recent talk article 2020 regarding type 1, type 2, and type 3 disorders, because beautiful tables are given there. And one question is really important from this aspect of management of the ovulation disorders. Now, the RCOG, we have got one PIL, that is ovarian hyperstimulation syndrome. However, for the others, we have got NHS patient information leaflet as well. We had been discussing about the template earlier, the same as we move across the stations, starting from the introduction agenda history taking. Please take the history of the partner who is affected, and from the other one, just ask that, are you generally fit and well? Okay, if you know the cause, please stick to the cause. If you do not know the cause, then of course you have to take a general history. But remember, in exam, they take care of this aspect that you know that what is the cause. May that be polycystic, may that be some sort of type 1 ovulation disorder, or may that be an ovarian failure. So you should be knowing that where you have to direct. Do not ask unnecessary questions. It has to be a focused history to go and squeeze it in just 4 minutes time. If it's a secondary subfertility, specifically take care of PID, the copper coil, the old history of postpartum hemorrhage, and failure to lactate as well. And when it comes to the gynecological obstetric medical history, family surgical drugs, please complete your template, complete the mental history if it's not an emergency, come to the examination, management according to the cause, address the patient's concern, and do a very good closure, confident closure to the station. So the sequence we are going to follow would be Liana and then Divya. Divya, have you joined? A little while ago, I couldn't see Divya in the session. I think still she's not joined. Okay. Harshaba, drop in a message for Divya, please, to join in. Okay. So let's start with Liana. Liana, can you unmute yourself? Can we check your mic?
Hello.
Hello. A little louder, sweetheart.
Hello, Dr. Sidra. I'm here.
Yeah, I can hear you. So how's everything going? How is the COVID situation in Malaysia?
Everything is okay. Still under restriction order. The kids all at home doing homeworks and online classes. So have to cope with the kids' classes and my class as
I
well.
know, I know. And how about the lockdown situation? Is it still going on?
It is still going on. Every day about 3 to 4,000 new cases per day.
They're still on a rise, huh?
Yep.
So hoping for the best, my dear. So let's go to the first station of the day, and I'm gonna fix your timer. It is going to be 2 minutes from now, and the time starts. Please go ahead. Good luck.
Next page, ma'am. Hello, my name is Dr. Liana. I'm the gynae doctor. May I confirm your name and age, please?
Doctor, I'm having severe pain in the lower tummy. Can you do something?
Yes, sure. I believe that you are Sarah Paul.
Yeah.
Have you received any pain relief so far?
Nothing here. I'm just in emergency. Nobody has come up till now, and I've not taken any medication. Please help me out.
Sure, Sarah. I would like to give you medication, but before that, can I confirm, do you have any allergy to any medication?
No.
All right, so I will let my nurse to give you some painkiller.
Yeah, that's okay. I also have vomiting, please.
I see, and also the medication for your vomiting.
Thank you.
All right. How do you feel now, Sarah?
A little better. Yeah, thank you.
Can I continue?
Yes, please.
Okay. I received a call from the emergency doctor telling me that you're having some tummy pain and some bloatingness. Is it right?
Yeah,
And
I'm
also,
having tummy pain since morning. And also, I've
mhm,
got some vomiting along with that. I was feeling sick for the last 2 days, but today I have vomited like thrice since morning.
that must be a difficult time for you, Sarah.
Yeah.
So, I from the notes also, I noted that you underwent some infertility treatment. Am I right?
Yeah. Today was my 14th day. I mean, it was actually eggs had to be taken out today.
All right. So they may I beg your pardon, Sarah. Today is what?
Today is my 14th day of the cycle. I received my yesterday's injection in time.
Oh, I see. Do you know what type of injection that you receive?
Don't know the name, but I'm receiving that daily.
Mm-hmm. All right. So, yeah,
I was told, doctor, that it is something to form my good eggs because I don't have like good eggs formation because I'm having polycystic ovarian syndrome.
I see. Yep.
Yeah,
I noted and in your notes that you are having the PCOS, and
yeah,
here noted that your
yeah,
BMI is 19. So, Sarah,
yeah,
in order for me to help you and formulate a management plan for you, can I ask you a few questions to know more about you, Sarah?
yeah. That's okay. Yeah.
Okay. So, have you ever been pregnant before, Sarah?
No, no,
No. Do you, how do you come here? Do you come with your partner or
no. I just came
alone?
with the driver. No partners
I
at
see.
office.
Okay. That you mentioned that the pain has been there for 2 days. Can you explain to me a little more about your symptom right now?
Yeah. What happened was around 2 to 3 days' time, I was feeling that my tummy is getting a little bigger. In terms of that, I was going to the
Mm-hmm.
market. I could not just close the upper button of my jeans, so that I felt that it's a little bigger tummy than before. Moreover, I started feeling sick for 2 days, but today it was vomiting, but it was very severe pain since morning, and my tummy I feel is bigger than before.
I see. Do you have some difficulty in breathing?
At the moment, no.
Mm, how about passing urine? Do you notice that you having reduced urine output?
I can't quantify, but yes, I felt that it's a little darker in the
I see.
morning. Yeah.
You must be having some dehydration right now. I would like to give you some uh, drip for hydrations. And then, have you noticed any leak or swelling anywhere in your
No,
low?
no, doctor, no.
I see. So, okay. I would like to ask a few more questions
Mm,
regarding your treatment.
yeah.
So, what did they tell you about this treatment? What is the plan?
The plan was that they had to take out the good quality eggs around 14, 15 day, they said, and then they said that they're going to have it meet up with my partner's sperm, and they were planning basically IVF for me.
I see. So, thank you for your information, Sarah. I need to do a full examinations on you,
Okay.
and also do a ultrasound scan to see on your pelvic area, to see
Uh,
your ovaries
just
and
just just 5 minutes before you came here, a nurse did that. She did examine me, and she also sent few investigations and performed an ultrasound as well.
I see. All right, Sarah, based on your examination, investigation, and ultrasound, after I confirm your name and your NHS number, in my here I can conclude that what you're having now, we suspect you're having OHSS, what we call as ovarian hyperstimulation syndrome. This
Mm-hmm.
is due to the fertility treatment. The injection that you receive can precipitate or can overstimulate the ovaries. Then this is what happened. This
Oh,
is a known case of complication of the fertility treatment.
I get that, but is it something serious? I
Uh,
mean, how can it affect me?
Actually, these symptoms can be resolved by its own for a few days. However, it can be worsened as well. So we need to, take a closer look and monitor you closely so that you are well and under control. So and it prevent you for getting worse. All right. We also have to uh, we also have to exclude other possibilities such as ruptured cysts, ectopic pregnancy, appendicitis, or also infection. So I also need to just to be safe to do urine pregnancy test for you also. All right. So Sarah,
Yeah.
the I would like to inform my consultant regarding your case. You might need to admit to our ward because this is considered a severe OHSS. All right.
A severe. Okay,
Yes,
but what if I can't get admitted? I mean, after 2 days, there's a big gathering planned at my home. It's my parents' anniversary.
I see. It has been planned out, isn't it?
Yeah.
All right. So, um, according to your examination now, you are currently stable and your pain also relieved by the painkiller. Actually, certain case of severe OHSS can be managed as outpatient as well. Do you have any problem in coming to a hospital for checkup if we let you go back home today?
No, no, I would be coming back whenever you want me to see you.
I see. So Sarah, after we will discuss back with my consultant. If he agreed, then I will let you to go back home. But you have to promise that you have to monitor your conditions. You have
Mm-hmm.
to take fluid regularly, and it's
Mm-hmm.
guided by thirst. And also, you need to monitor your urine output. Your urine output has to be more than 1 liter over 24 hours. And I also encourage you to ambulate. Walking around and wearing some pressure stockings. This is to prevent the blood clot formation from your legs. All right. So you may also need to be started on blood thinning injection for that purpose. So we need to see you every 2 to 3 days, and if you feel that the symptoms is worsened, you need to come to us early, and we will also provide you with the 24-hour contact details. Right. This case, because you're having this severe OHSS, we need to report to your fertility center so that your fertility center can report to the HFEA for further reporting and follow up. All right. So,
I get
mhm.
that. So just one thing that what do I need to take now? I mean, what medications?
All right. So I will provide you with the painkiller, the vomiting medications. There's one type medication we should avoid. It is NSAIDs because it can compromise your renal function, and as well as because you feel some bloatingness in your tummy, and from the scan it shows that there's a free fluid inside of your tummy. We
Mm-hmm.
might need to do the what we call as draining of the fluid from your tummy, and it can be done under ultrasound guidance.
Now?
If it's worsened, or if it's your urine output is not improved by fluid intake. Okay.
I get
However,
that.
if the condition worsen, we might need to consider admission for you. All right. So this is where if the pain not control, if you are unable to take fluid properly, and if there's worsening signs of OHSS, and also if you cannot come for the follow up, we suggest you for close monitoring in our hospital.
Okay. All right.
Mm-hmm.
Yeah. Wind up.
Um,
Time is up.
Thanks. Provide you with the patient information leaflet. If anything, you can call us back in any time. Thank you.
Okay, thank you very much. How did the station go, Liana? First station and ovarian hyperstimulation syndrome. How was
It's
the experience?
haywire. It's haywire. I'm so sorry, Dr. Sidra.
No, what about why is the reason? What is the reason behind being sorry? I mean, it was a very good station, and in fact, you did do the patient safety part, more or less, though there was one thing which I was expecting. But otherwise, it was a very beautiful station to start with. I mean, you settled my pain in the very beginning. There were many good points, Liana. Very well done. Yes, friends, how did the Liana station go at the top? Rehma, Abir, Harshiba, Dua. How was the station? Very well done. Dr. Sujata says that she's very happy with your presentation. All right. So there were many good points which were done by Liana, and this is what we had been practicing in all the yes, Dr. Sujata, we are going to come to this point that what are those things which we are going to do for the safety. Right. Very good, Dua. So initial starting was very good, Liana. You did confirm the name and you were very composed. The best thing was, friends, that when I was coming up with pain, Liana was very comfortable talking, and she didn't push me for this thing that, no, I keep on talking with my pain. So she was comfortable in the sense that she didn't lose her composure in my being an emergency situation and asking for some pain relief and all. She had a very composed voice, and I was very happy on your handling at the top of the station. So then you did ask my permission to continue. Yes, she did, Abir. She did confirm allergy. That was very good. At the very beginning, she did confirm allergy. So then you made a very good agenda, and then you started with the asking questions. Now, asking questions a little up and down they were. I'll tell you that where I have to tell you about the open question. However, you did ask about the current cycle, about the injection, about what types of injection, what treatment I'm undergoing. And you did ask about my breathing difficulty, about my urine output, about the swelling in the legs. All these were good points. And after asking about the swelling in the legs, there was a little problem in like did you complete the other template of the history, Liana?
I don't know, maybe
The medical history, the surgical history,
oh yeah, no, I haven't.
the family history, or the support and all. Yeah. So any other comorbidities, any surgery in the past. Yeah, just one line. So the template was over on HOPI, basically, history of presenting illness, and you came to the OHSS. Okay. So there you had to complete your one line for each. Do you remember? Yeah. So that once we do the history of presenting illness, we have to complete our template regarding the other, just one line for each type of history. So that was one thing which is important. You were saved in this aspect that you did ask about the allergy at the top. So that was something really good, that allergy was not missed. However, rest, smoking, alcohol, yeah, all these things, they were best. Even if it's an emergency situation, just ask about the medical history or surgical history, because that definitely affects your management plan, and you come to know about some basic information about the patient. You came to the OHS's explanation. That was fine, that this is basically a side effect of the complication of the fertility treatment you're having. And then you did send some investigations, urine pregnancy test. You did tell the consultant you wanted me to get admitted. The best thing was that you classified the OHSS correctly. Okay, friends, so what was the classification of this ovarian hyperstimulation syndrome? Was it severe? Was it critical? Was it moderate? Was it mild? What type of OHSS was this? And was Liana right in this, that this is the, oops, Rehma says it's mild. Rehma, let me change.
Because
Abir says it's moderate. Dua says it's mild to moderate. Noopsie, Harshiba says severe. Thank you, Harshiba. Dua, Abir, Dr. Rehma, this was severe for the reason that hematocrit is 46%. Remember, I teach this to my part 2 students as well, that in extended match question, if so ever something has touched to one step ahead in the classification, you never go back. You never go back. For example, the ovarian size here, that doesn't go with severe. It is 7 centimeter. But if anything in the investigation is going to the classification one step ahead, okay? If it's going one step ahead, remember that it has to be the one step ahead classified and not the back one. Always keep a note. So it was 46%. Yes, it's the severe form of the ovarian hyperstimulation syndrome. Now, coming to the point that you did explain, you wanted me to get admitted. I was very happy on this. But because of my concern, you did ensure that I would come to you in just 2 to 3 days to have a good follow-up. And you asked me to drink on thirst. You reported to the fertility center, the treatment plan team, and you gave me medications, the painkillers, beautifully telling me that I have to avoid NSAIDs. And you gave me medications for vomiting and sickness as well. You did tell me that I might require, if the worsening situation is there, with a needle, removal of the fluid might be required. So all these points were very good points. Now coming to the points to improve. I was happy with in starting, Liana. However, your first question in the history taking was, do you remember? What was the first question in the history taking? Liana, what was your first question in the history taking?
Have you ever been pregnant before?
Very well done. Was it the presenting complaint?
No.
Yes. So that was something which I wasn't expected. That is a good question, but that would come a little down in the history taking. Now, after this question, you asked the correct question. So you told me that you're having pain. May I know more about that? So that was a perfect question. So that was the first question I was expecting. So the first question would be that, may I know more about your symptoms? May I know more about your problem? So can you tell me detail about this? So any one sentence out of this, right? Got it, Liana? Yeah. Then about the previous pregnancy, sweetheart, you'll come to it later, but make it a habit that HOPI, history of presenting illness, starts with the presenting complaint. Her presenting complaint at the moment is she's having pain, she's having sickness. This is the presenting complaint. She's having bloatment. These are the things which you have to rule out first. And then, of course, you're going to come back to in the obstetric history about the previous pregnancies. You need to ask, but that is going to be later in the history, okay? Not at the top. That's number one. Number two, I would like you to complete the other template in a quick, just 15 seconds, but definitely yes, because information gathering was one of the domain. And that's the reason that made me give you a borderline in the information gathering, just because of this reason that these points were missed, okay? Now, after this, you gave me fluids in the beginning, but see, you said that you might be, when I said that urine is darker, what was your answer? So with that, we are going to give you some drips in the arm. Yeah?
Yes, ma'am. That's my mistake.
Yeah. So we don't give the fluids here. We have a very controlled input and output charting. So immediately when I said my urine is darker, doctor, you said that we are going to give fluids your drips in the arm. So we are going to avoid that at this point in time. When we come to the management, we'll say the correct sentence, as you said, that we are going to offer you drinking water according to thirst, taking fluids according to thirst. So that is what we need to understand. Got it? Yeah? So fluids in the drip, it's going to be against patient safety. We do not do overhydration, or even we don't give that, because we know that they're going all into the third space. All right. Now, I was happy with the referring to the fertility center. However, I would add one point which Dr. Sujata also noticed, that they might suggest this cycle to be cancelled, because if the pregnancy occurs with this condition, the complication rates are higher, Sarah. I hope I'm clear. So this is going to be 1 point, cancellation of the cycle in OHSS. That is again a patient safety. You did offer me the ambulation in terms of movement being more, not to be static. You did offer me the stockings as well. However, in severe OHSS, remember that low molecular weight heparin is one of the indications for severe and critical. So I won't say that we are going to give because she's going home. However, I would say that we are going to assess you. If required, the blood thinners would also be given in this point in time. Okay, low molecular weight heparin as per the guidelines starts at severe OHSS. Got it? Yeah, Liana? All right. So instead of renal functioning, I would say that there are certain group of drugs which we are going to avoid as pain relief because they affect your kidneys. Okay, affect the kidney function rather than the renal function. Am I clear, Liana? All right. Yes, so all these points were good points. All these points were slight, which we have to add on. There's one point for which I cannot pass the patient's safety despite multiple points had been mentioned, like informing the fertility center, like admitting her first or starting the correct management plan, drinking to thirst, not giving an asset. But still, there's one point which I would like to hear from your side. All of you, please, it's an open question. What is that one point which I would like to have as an asterisk point in the patient safety, please? Waiting from your side. UPT, she did do that, Harshiba, though I was at 14th day, but Liana did go. No coitus. So Dr. Sujata is right, but though that's not the point about which one point I'm asking. However, remember, whenever the patient goes back home, you always tell her that there's a suggestion is that don't do any aggressive exercise or avoid sex. Because as a complication at times, these ovaries, which are larger in size, they can turn around and can land up into a life-threatening situation. So yes, sex avoiding and the avoiding exercise, aggressive exercise, that has to be avoided. While she's going back home, you tell that. But there's one more point which I would like to listen, please. I would like to listen to that point because this is something for which I cannot pass the patient's safety. Yes, the house is open. You can do a little discussion as well. Tell me, what do you think is one point? Dr. Sujata's point is fine, but I would have ignored that on the good points she has done. But one point I cannot ignore. Liana, danger signs, yes, she did that. Harshiba, danger signs, she did that. That if you feel that things are worsening, 24/7 hospital contact number, she did give that, Harshiba. Yeah, Dr. Sujata, she did give me she did ask me about my difficulty in breathing. Yes. Anyone? Dr. Sabiha, where are others? All of you, please. One patient safety point I want for which I cannot pass the patient safety, please. In an ovarian hyperstimulation syndrome, that too a severe one. Abdominal pain not settled. Yeah, okay, that's fine. She did tell me that if the things are not better, we are going to admit you. So Liana did touch that point. Okay, $1,000,000 question. No?
I cannot think of that one point. Man.
1 point. Okay, let me give a clue. Should I give a clue?
Yes.
Yes. Okay, the clue is that it's related to referral to the fertility center informing HIFA.
Incident reporting.
Thank you very much, Dr. I can listen to my echo. All right. Very well. Go on the mute mode. Thank you. Okay, wonderful. Please remember that if you do not initiate an incident report, that means that you're not understanding that this is a complication that should not happen. This is something we know that she's having polycystic ovarian syndrome. She has a BMI of 19. She has got 2 risk factors. She is otherwise high risk for OHSS if it has occurred. That is on our part that we did not manage the condition well. So you always say that, Sarah, we are going to initiate the incident report as to what was the reason behind this complication to occur. As soon as it gets completed, we are going to be open, honest, and transparent about the happening to you. Is that okay? I apologize once again that the care you received did not match to the expectations. Remember, it is a known complication. However, it is not mandatory that this complication has to occur. Why? Because we've got some other points where we avoid OHSS to occur. As per the clinical governance paper, remember this is a trigger for incident report. Am I clear, everyone? Liana, I'm sure you'll never forget in life now.
Yes, I never forget this.
We have to initiate incident report for this. Thank you very much, Dr. Sujata. So the clue worked. Thank you very much, my dear. Let's see the examiner's key now. The greeting, introduction, self-enroll, check, the patient's name, that was all fine. Consent to proceed and explaining nature of the interview, setting the agenda, attentive listening it was. You can also draw a little diagram for visual aid using for her to understand what OHSS means. And you have to tell her that this is one of the side effects of the fertility treatment. When the ovaries, they're overstimulated by the drugs which we use to produce the eggs. And these overstimulated ovaries, they produce certain chemicals, Sarah. These chemical substances affect the body in various ways, leading to the symptoms of ovarian hyperstimulation syndrome. So this is about OHSS. Remember, history and the points in the HOPI would be regarding the symptoms, which beautifully were asked about by Liana. And she did ask about the current day of the cycle and what injection being used, and the eggs were not collected at the moment, but if at all they were collected, please always ask how many eggs are collected. So this part was missing, for which I have to give you borderline information gathering. Always complete your next part of the history. If it's an emergency situation, you can ignore mental history, but otherwise the personal, drugs, social, family, medical, all these are important. Now, examination was already done, Liana. So if it's done, you can simply say that your examination and the investigations, they say. You've confirmed the name and the NHS number, so that was very wonderful. And then you told the correct diagnosis as well. So these were two aesthetic points in the station. Number one, informing HIFA and IVF unit and the incident report, severe and critical. Remember, the clinical governance paper says for mild and moderate, it's okay. But for severe OHSS, you need to initiate an incident report. Remember, these two are the aesthetic points. One was wonderfully touched by Liana. However, this was not only missed by Liana, in fact, everybody missed that. When I asked an open question, it was in none's mind that yes, we have to initiate an incident report. So please keep a note in exam that incident report is mandatory for passing patient safety. Now, this is the categorization of the ovarian hyperstimulation syndrome, the mild, the moderate, the severe, and the critical. Now, 46 hematocrit was there. When it is a 46 hematocrit, yes, we have to do the severe OHSS. However, you need to remember that even if it's 7 centimeter, so if it was mild OHSS in terms of the ovarian size, that becomes secondary. So if it was a hematocrit of 46% and it had a white blood cell count of 26,000, what would be the classification, severe or critical? What would be the classification, severe or critical? 26,000 WBCs and 46%. Very well done, Dr. Rehma. Very well done. So always remember, if any point has been touched from the one step next category, we always follow that next category. Okay? So for your ease, please remember the guideline says that it has to be a home management for mild, home management for moderate. For severe, they say it has to be a hospital. However, in outpatient management is appropriate for women with mild or moderate, but in selected cases of severe, it can be a management at home as well, but it's never preferred. High dependency unit is in the critical, so always keep in mind that critical has to be in HDU. In these patients, we have got two risk factors, polycystic ovarian syndrome and thin lean patients. Other than that, there are other risk factors as well. You should be knowing of the previous history of OHSS, increased AFC count, the angel follicular count, increased levels of anti-malarian hormones as well. Coming to the applied clinical knowledge. We've got 4 categories of mild, moderate, severe, and critical. I need to tell you one thing more, that whenever it's mild and moderate, it's okay. It can be an outpatient management. In severe and critical, it has a team of doctors. We need input from anesthesia doctors as well. We need input from the consultant as well, and a specialized nurse as well. So when it comes to severe and critical, go with the MDT to begin with. Sarah, we are going to counsel you about the fluid intake and the output monitoring. The pain relief, we are going to give you medications starting from today, avoiding certain groups of medications which affect the kidneys, and also medications to prevent the vomiting. We are going to assess your state, provide you with the compression stockings. Along with that, the blood thinners assessment would be performed and would be started if required. There's fluid in the tummy, as I've told you earlier. If at all the things they improve, the symptoms are not worsened, we are not going to do any intervention. However, there are few conditions in which we have to take the fluid out with the help of an ultrasound guidance in case it causes you shortness of breath or if at all, the output of the urine, it's not adequate despite the fluid intake management is done. Now, if you're going to go back home, we would suggest seeing you again every 2 to 3 days, for which we are going to monitor about your signs and symptoms that they're improving. If you're going to be admitted with us today, we are going to review you once daily to analyze the situation. Would that be okay? So according to her decision, please tell her about the review. All right. So OHS's outline, friends, introduction, agenda, information gathering. Please explain the diagnosis first and do the evidence-based management plan. Address her concerns. It should be a mutually agreed plan and come to the follow-up. All right. So this is all the important points of the OHS's outline, which you need to remember. Always remember that settling the patient at the beginning, it was a wonderful settlement by Liana. Please follow the way she has done. I was very comfortable as a patient. Do not forget, I repeat, do not forget incident reporting in more severe and critical OHSS. Am I clear, friends? Any questions regarding ovarian hyperstimulation?
Dr. Sidra,
Yes, Dr.
in
Yes,
mild and moderate, do we advise blood thinners or just stockings and ambulation?
Dr. Sujata, why am I having echo at the back?
Oh. Can you hear me now?
Two devices.
No.
Okay. All right.
Only one.
All right. Ask the question again.
Yeah. In mild and moderate OHSS, do we give heparin?
No. The indication is from severe. Why?
Okay.
Because the hemoconcentration
starts then. Okay. Thank you.
Thank you very much.
Thank you.
All right, friends. So we are done with the OHSS. Lots of claps for Liana. We are going to see her again after a few stations. Thank you very much, Liana, for a wonderful start, my dear.
Thank you so much, Dr. Sidra.
Thank you very much. A wonderful start to the station. Just don't forget the completing the template of information gathering, and just don't forget the incident report. Otherwise, it was a perfect station, my dear. Very well done. Okay, so let's go to the second station of the day. And do we have Divya here? Hello, Divya. Hello, Divya. Not joined? No, she's not answering. And she didn't ask for any exchange as well, right? Yeah? Okay. Okay, so in the group, she didn't write for any exchange. Okay, no problem. So let's have Sarvat then. Hello, Dr. Sarvat. Hello. Do we have Dr. Sarvat here? Hello, Dr. Sabiha, Dr. Atia. Do we have Sarvat here? Friends, I can understand the registrations of the exam has not started yet. Hello.
She's not. Hello. I can't see her in the group.
Okay, so Liana OHSS, and then I think Dr. Sujata, we'll have to begin with you now.
She's not joined, Dr. Sidra. She's here.
Everything okay, Dr. Sabia?
Sarvat is not there. Sarvat is not there. I did not have any talk.
Okay.
There.
So let's start with Dr. Sujata. But Dr. Sujata is on paper. There's an echo.
Can you, is it nice now?
Hello.
Yeah,
No.
can you hear me now?
Listen to my voice again. Harshaba, Rama, can you listen to my voice echo as well?
It's echoing, Dr. Sidra.
Yeah,
It's echoing.
When you unmute yourself, you listen to our voice again. Server speaks.
Hello.
Dr. Sujata?
Yes. Can you hear me?
Yes, now it's okay. Yeah. Speak a little more, please.
Yeah. Can you hear me?
Yes, that's fine. Okay, Dr. Athiya, hello, how are you? Sarvat said that she might get duty but had no chat since 3 days. Okay, so do tell me that if somebody wants to exchange or if it's her last station, then we are going to see. Okay, all right, thank you. All right, Dr. Sujata, we are going to do the station, the second station, and
Okay.
let's start the 2 minutes time. Yes, please.
Next slide.
Start, please.
Yeah. I'm Dr. Sujata, one of the doctors in the fertility clinic today. Can I confirm your name and age?
Yeah, hi, doctor. Doctor, I'm Jazz Paul.
Yeah.
I'm 28 years.
And how do I call you?
Yeah, Jazz is all right.
Yeah. Jess, I see that you are trying for a baby for the last 2 years and you have done some tests and you have come to discuss that today. Is that right?
Yeah, exactly.
Can you tell me more about what all tests were done and why you did it?
Yeah, it was like 1 years when I was not getting pregnant. They did all the investigations, the hormone test as well, and they said that they're going to test me on that. Everything was fine, and now it's been 2 years. They planned for the teeth test. I just had it few days back.
Okay. Yeah. And was there any pain following the tube test?
During the tube test, it was very painful.
Okay. Are you feeling better now?
Yeah, it's okay now.
Okay. Okay. Before we come to your tube test, can I ask few questions so that I can know more about you?
That's okay.
Yeah. So, how are your periods? Tell me about your period cycles.
No problem with the cycles. They're always spot on time. No issue at all.
Okay. And when was your last period?
Yeah, that was around 3 weeks back.
3 weeks back. Okay. And when was the tube test done?
Yeah, it was around 10th day of my cycle perfectly, yes.
Oh, okay. And have you, please don't mind if I ask some personal questions. Have you had any sexually shared infections before?
I don't know exactly. It's a sexually shared infection. However, I did have a vaginal discharge 6 months back. I was treated for this.
And now we are better?
Yeah, it's okay. I took treatment for that, and then test was done. It was all normal.
Okay. And how about your sexual life? Is there any problem with intercourse?
No.
And what is the frequency?
Maybe thrice a week.
Okay. And have you been pregnant before, Jess?
I don't have kids.
Okay. Okay. And have you had any medical illness for which you are taking treatment with a GP?
No, I'm otherwise fit and well.
And any surgeries before?
No.
Do you have any known allergies?
No, doctor.
Okay. Are you aware of your height for weight ratio?
Yeah, that's fine. There's 23.
Okay. And what about, do you smoke?
I used to do that, but now we are planning a baby, so I've tried to cut it down.
That's very nice. It's good. And what about taking alcohol?
No.
Okay. And what about recreational drugs?
No.
Is there any family history of concern that you'd like to tell me?
No, everything is all right, doctor.
Okay. What about your partner?
He's fine, and he also underwent investigations. His semen analysis was absolutely normal.
Okay. And he's supportive?
Yeah, he is.
Okay. So thank you for the information. And can I examine you with your consent in the presence of a chaperone?
That's
I'd
absolutely
like,
fine. Yeah.
okay. I'd like to check your blood pressure and your height and weight, and check your tummy for any masses, and look down below for any discharge. Okay. And then coming to your investigation, this is the tube testing which was done. I've confirmed that it belongs to you with your name and NHS number. And I have some concerning news for you. Are you alone?
Yeah.
Is it okay that I tell you the report?
Yes, please. Yes.
Yeah, so I'll draw and show this is your womb, and it has 2 tubes. That is why the test was done, to see if your tubes are patent. That is the portal for the egg and the sperm to meet. And in this report, it's showing that we cannot see the right tube. It is blocked. So the dye has not gone into the right tube. And in your left tube, it is swollen with fluid, and there is no flow of dye into your tummy. So that means,
what does that mean?
That means both your tubes are blocked. That is why you are not able to get pregnant, because all your other investigations are normal. But so that you need not get worried. We can do some surgery to make sure that we can put in a camera test and see and remove this tube which is filled with fluid, and we can see what else is wrong inside your tummy. And
sorry, doctor, I didn't get you that you're saying that we are going to remove the tube?
No, this tube is filled with fluid. That's what the dye test is showing, the X-ray is showing. So
which
that
tube is filled with fluid, doctor?
The left tube, it has not, the dye has not come out.
Okay.
It's filled. So we would like to do another test to confirm how the tube is, because the right tube has not got filled. And the left tube is filled, but it has not spilled. So it looks as if it is blocked.
I understand.
So the next step will be to do a camera test to see how the tubes look, the outer surface of the tubes, and we can put in a dye and confirm that it is blocked or whether it is open. And you said about a vaginal discharge. Maybe we can check again whether there is any infection there. And from there on, once we confirm whether the tube is patent, then we'll move on to the next option for your pregnancy, because you said your partner's semen test is also normal and you've tried for 2 years. So most probably the problem is in your tubes, because the right tube is blocked and the left tube also has not split in the X-ray. So in the laparoscopy, we'll be able to confirm. And then the next option we could offer to you will be a test tube baby, because we have already waited for 2 years. And do you know what is test tube baby?
Yeah, I know that. What I mean to say is that can there be any possibility that this investigation result is wrong?
Yeah, when we do the this camera test, we will be able to know for sure whether we'll be able to push a dye through the womb from below, and we'll be seeing from a camera from above. Then we'll be very sure whether the tubes are blocked.
All right.
Is it all right?
Yeah, I get that. Okay. So there are chances that after the surgery, I'm going to be pregnant?
Once we do if there is free spill, then sometimes due to spasm also the tube might not get filled. So we have to wait and see, depending on what we find in the surgery, the next step will be told to you. So I'll book you a consultation with my consultant, and I will also like to give you some information leaflets regarding how the tube can affect your chances of pregnancy. I hope I have made myself clear to you.
Yeah,
Yes?
I get that, doctor. Yes, thank you very much. So for now, what do I need to do?
Now you have to, I will give you an appointment with my consultant for the next test, the camera test, the keyhole surgery test.
Okay, right. Thank you very much.
Okay.
All right. So how was the station, Dr. Sujata?
Could have done better, not able to.
No problem at all. Let's discuss the positives first. So what are those things which we did good in the station? Again, a little echo is at the back. If you could just slow down the voice of the device.
Okay. Now is it better?
Let me speak up. Yes, now it's okay. All right. So please tell me that what are those good things? Yes, friends, Dr. Sabia, Dr. Atia, Abir, Rahma, what are the good things Dr. Sujata did? Harshipa, Dua? Yes? Yes, Dr. Sujata, let's pinpoint the things which were good. Yes, Dr. Sabia, I've noticed. Thank you, Dr. Atia. I've noticed. Yes, thank you very much. Drawing, okay, that's fine. BBN, perfect. These are all good points. Very well done. So starting was fine. A very smooth history, a very good open question, and asking about the history one after the other. That was very smooth. Dr. Sujata wasn't fumbling in the history. She knew what question needs to be asked. A wonderful history taking. Undoubtedly, that was the strength of the station. A very structured and composed history taking it was. Very well done. There were many good points, like starting with the jazz, asking about the open question. Did ask me whether that was painful or not, and she did ask me about my last periods, the medical, surgical, allergies, all were asked. Examined me, did a BBN, breaking bad news, that was very important, and all these points, they were important, contributing to this point. Laparoscopy as a gold standard was given. That was okay. Information leaflet and consultant decision was offered in the end, right? So yes, cervical screening, I'm coming to the points to improve. Okay, now tell me that what could have been better. Dr. Sujata, what did you feel? Yes, all of you please in the chat box. If you would have been at her place, anything in a different way you could have done for this station? Yes, Dr. Sujata, you yourself, if you can, if you're given a second opportunity, what would you have done now?
Yeah, I would say that this X-ray test has to be confirmed with a laparoscopy.
Thank you very much. Other than that,
because due to spasm,
very well,
dye would not
very
have
well
spilled.
done. This was the first point that you should tell her that there are chances that the tube is not blocked, and because of the pain condition at that point in time, the tubes, they go into spasm and it appears as a block in the X-ray picture. So we've got two options for that: repeating the tube test again under a good painkiller, yeah, or going directly to the keyhole surgery. So that first point of repetition was not given. She says
Yes.
it was very painful, so it can be a tubal spasm as well. Okay,
Yeah.
so
Yeah,
this was
yeah.
the starting which I wanted to hear in applied clinical knowledge.
Yes.
Information gathering
Understood.
goes 2 by 2. Communication with the patient goes 2 by 2 because of PBN. I was very happy that you did not miss that. Applied clinical knowledge would go around 1 to 1.5 and patient safety 1 to 1.5 because I wanted to hear that it can be a spasm
be.
rather than a true blockage. Okay,
Okay.
this is what I wanted to hear. So these are
Sure.
few points. Yeah, one more thing, Dr. Sujata. When I said that I'm cutting down on smoking, what is the ideal way of appreciation rather than saying that's very nice? I appreciate that. Yeah,
Yeah.
I appreciate that. All right, rather than saying that's very
Stop
nice.
smoking.
And yeah, and when you
I
came to
should
the
have-
report, I would like you
Yeah.
to speak of the same thing as Liana did, that I have confirmed your name and NHS number.
That
and-
I did.
Yeah?
Yes, I did.
Okay, that's perfect. Well done. So let's see the communication with the patient. You did check my understanding. You were a very attentive listener. You had a very wonderful mild signposting to break the bad news. Anybody who is planning to have a baby and you come up with this report, a result that it's a block of the tube, of course, it's a bad news for that couple, for that patient specifically. It was a wonderful history of a tubal blockade. You did ask about the vaginal discharge. Also, you can ask about the tuberculosis, because we know that whenever it comes to the blockade, we are worried about either PID, number one, and the second thing is the tuberculosis that also tends to affect the patency of the tube. So two things which we are going to be careful about when asking this question, right? You did confirm the gynae, the obstetric medical history, cervical screening. You can add on this. She's 28 years.
Yes.
So that's something
Yes.
that's going to give you an additional information regarding the STIs as well, if there is some sort of an abnormality, because HPV that also has an, we know that it's because of the sexually transmitted infections. Now, you did examine, that was all right. In patient safety, explanation of the diagnosis, I was comfortable with. Just what I want to add is that you should be knowing that there's a chance that it's not a blockage. So always keep patient safety in mind. It is always important to rule out the possibility of the tubal spasm, and involving the patient in the process. It should be a mutually agreed, safe, and an acceptable plan of management.
Okay.
Now, all of you, please listen to me very carefully. I have something important to tell all of you, that always in the case of the subfertility module, always give the options. Like for this patient, I would say that there's an option of repeating the tube test again with the pain relief. We also have the ultrasound-based assessment, though it is not preferred and expertise is required for that, but that is an alternative option to check for the tubes. The gold standard or the best method is through the keyhole surgery. And if we find out that the tubes are blocked in the keyhole surgery, we can plan the treatment of opening up the tube in the same setting as well. And we are going to talk to you prior and take consent about that. Now, Jazz, success depends upon the type and the site of the blockade. At times, if it's at the proximal aspect of the tube, the chances of success are higher, but at times, if the tube blockade is more, the pregnancy might not be successful even after performing this surgery. And one of the complications is that when we deal with the surgery of the tubes, the chances of having a pregnancy next time in the tube is also higher. So if pregnancy test is positive, we perform an early scan to rule out the pregnancy in the tube. Would that be okay? If nothing works for these patients, we have got the assisted reproductive method in which the egg has a meetup with the partner's sperm in the laboratory, and when the baby is formed, is placed inside the womb. We call it as IVF, the test tube baby. Still, if nothing works for a couple, they've got as a last resort, the option of adoption as well. Am I clear about all the management options and how we are going to proceed? Would you like me to repeat anything for you? I'm here to answer all your concerns, Jazz. Got it, everyone? So follow the sequence, please. Remember that IVF and adoption is always the last option, and keep it in your applied clinical knowledge, because that is something that your applied clinical knowledge doesn't stop here. What if it doesn't work? Yes, we've got IVF. What if it doesn't work? Yes, we've got adoption. Am I clear? Mentioning this as part of your applied clinical knowledge, please start with ruling out the possibility of a spasm. So always do. Why not directly keyhole surgery? Because the keyhole surgery is invasive. We know that it's under general anesthesia. So always it's better that if you have a clue that the patient was in pain, it's always better that you start with repeating the tube test and the extra pictures under the good pain relief. Okay, that is a patient-safe choice. So you always give that option to the patient. If you go to the outline, introduction, agenda, information gathering, explaining the diagnosis, coming up with a management plan, addressing your concerns, mutually agreed plan, follow-up patient information leaflet, and the support group regarding this condition. Any questions regarding this? Yes, Dr. Sujata, am I clear about those tiny points where we have to improve together?
Yes,
Yes?
thank you.
Thank you very much, Dr. Sujata. Always lovely listening to your voice. And I'm sure once Girija and Jyoti, they're back, the group would be back with a good practice, yeah?
Yes.
Yes? Okay, thank you. Very well done, very well. Okay, thank you for presenting the second station, though I had kept a little difficult for you, but this station was actually for a choice because Divya was not here. Thank you very much. All right. Okay, so any questions regarding this, friends? Now you people must be master in this exam question because it was a spasm. So you have to rule out first and then you have to move forward. All right, so coming to the next presentation, the structured discussion. Thank you very much, Dua. Third topic had to be by Divya. Divya, where are you? I'll leave that then. Wait, let me pause the screen. Okay, so who is going to do the third station then? It's going to be Dr. Siddhartha is done. Again, we have got Liana, we have got Dr. Sabia, and we have got Dua. Dua, would you like to do the station?
Okay, Dr. Seda, no problem.
Okay, that's wonderful. Dr. Sabia? Next, okay, Dr. Sabia. Dr. Sabia, you're available in the session today, right? You can do next to Dua? Yes, Dr. Sabia? Would you do the station next to Dua, please?
Yes, I will do next to Dua.
Thank you very much, Dr. Sabia. I'm grateful. All right. So we are going to have Dua now, and the time 2 minutes Dua. It starts now, please. Let's move ahead.
Okay, Dr. Seda, next. Hello?
Yes, go ahead.
Okay, next, please. Okay, the first slide, please.
Sure.
Okay. Hello, I am Dr. Dua, one of the doctors in the clinic today. Can I confirm your name and age, please?
Hi, doctor. Doctor, I'm Amanda Thomas. I'm 27 years, doctor.
How would you like me to address you?
Amanda is all right.
Okay, Amanda. Amanda, as I understand from your case note that you are here today because you are anxious to have a baby, but you have some problem in that. Am I correct?
Yeah, exactly, doctor. And I'm really desperate to have a baby, and that's really affecting my life, my partner's relation with me. I need your help.
I'm really sorry to hear that for you. Don't worry. In a moment, we will discuss all your condition and we will try to find a safe, mutually acceptable plan for your management. But before that, please, can I ask you some question to know more about your condition?
Yeah, that's okay.
Okay, can you tell me more about your problem in your own word, please?
It's a little personal, doctor. Can I talk to you about that?
Of course, if you would like to talk, I promise you everything here will be confidential unless it will affect your safety.
Yeah,
But
that's
otherwise,
okay.
that's okay.
Yeah, that's okay. I mean, I don't have the trouble in this. The actual problem is, doctor, that I feel that there's some sort of a barrier in a sense that it's a closed place. I don't actually understand that why is it happening, but it's from the start of my sexual life that I'm having this trouble. I don't know what's the problem, but it's a simple blockade. It's a blockade. I mean, even the doctor tried to do the vaginal scan, could not go inside. I don't know. I cannot carry out the sexual intercourse with comfort, and it is not complete at all. Since the beginning of my sexual life, it's not complete at all.
Sorry, I didn't hear the last paragraph. What you said?
From the start of my sexual activity, I've never had a complete intercourse, what you call like a deep sex.
Mm-hmm. I'm really sorry. I'm really sorry for that, Amanda. I really understand it must be difficult for you and how it affects your life. But we will investigate that and we will try to find a solution for you. But what I understand from you that you never had a penetrating sex before. Am I correct?
Yeah.
Okay. And what about your period? You have period or not?
I never had a problem with periods. I started having them around 13 or 12 or 13 years of age, and they're always normal on date.
Okay. Any history of any abnormal discharge or pain?
No.
Okay, that's good. And apart from these problems, do you have any problem in your water work or opening your bowel?
No.
Okay. Amanda, just I want to ask you some personal question. I'm really sorry if you find my question intruding, but really it can help in your management. Everyone, as a woman or as a child, maybe they can expose to some bad memories in their life. Do you have exposed to something like that before? And I want to assure you, whatever you will say, it will be confidential.
No, doctor, it's nothing like that. I feel that there's something like physical barrier. I don't know how to make you understand. Since I started my sex, I had this problem. I don't know how to guide you. I mean, it's only around 1 to 2 inches that's going inside. Yeah, I mean.
Yeah, I got to understand your point. I
really enjoy sex. I really have fun during that. I really want that it occurs deep, but it's not happening.
Okay, and apart from this condition, do you have? As I understand, you didn't get your smear before. Am I correct?
Actually, it was an invitation, but I couldn't go for that. I missed my first invitation. Yes.
Okay, and apart from that, you are generally fit and well.
Yeah, I don't have any problem.
Okay, any allergy for any medication?
No, doctor.
Okay, any surgery you have done before in your tummy or down below?
No, doctor.
Okay, that's good. Any family history of concern you want to share with me?
Not anything important that I know of.
Okay, and apart from that, some question about your social life choices. Do you smoke, drinking alcohol, or any recreational drugs?
And now, as I'm planning a baby, so I'm not doing that.
That's good. I appreciate that. And do you feel low or depressed in the last few weeks?
Definitely, yes. It's not because I have some other problem. It's just because that now I'm desperate. That was the reason that I'm not getting pregnant. Of course, my partner loves me a lot, and he really is desperate to have a baby.
Okay. And apart from this condition, as I saw that you did some investigation for you and your husband. Do you review your husband result? Do you know about it?
I know his results are always normal. I don't know about mine.
Okay. Anything else you want to add before going to explanation of
Well,
your
that's
result
it.
test?
Please tell me that what's happening and how can I get pregnant?
Okay. Now coming to your result, Amanda, after confirmation of your name and NHS number, you did some blood test. As I see here, your blood test, it looks for the hormonal profile for you, it looks okay. But apart from there's a hormone called the progesterone, it indicates if you release egg on time or not. This hormone is a little bit below the average. So maybe about the egg release, we have to confirm that by another hormones or another test to be done. As regard the other test that you did, as I see here, you did a scan.
Yeah.
Please. You did the scan here. It's mentioned as you told me that I confirmed also your name and the NHS number for this scan result. The scan showed that you cannot tolerate the scan to be done from down below, but they tried to do the scan for you through your tummy. And according to the result, it showed to me here that the study is normal. You don't have any problem in your ovaries or in your womb according to the result of the scan.
Yeah.
So what we are going to do now, if you don't mind, I want to examine you in the presence of chaperone after your consent. I want to have a look from down below to check if, like you said, if there is a physical barrier already exists, so we can understand more about your problem. Is it okay?
That's okay. Yes, it's a vaginal septum. Go ahead.
Okay. As I see here, you are correct in your explanation, Amanda. You have like a muscle barrier. It blocked the vagina from down below.
What do you mean,
So,
doctor? I mean, how did it block? I'm having normal periods, doctor.
yes, sometimes the period is not a matter because this septum or this muscle barrier, it's not a complete. So you can get a period, but the problem that you cannot have a complete sex or complete sexual intercourse. So that's why you can
From
have.
where the periods they actually pass?
Because as I told you, this septum or this muscle barrier, sometimes it's not complete, closing the area from down below. So there's, the period is like a fluid. It can pass through it, but for the complete intercourse, it will be difficult for you to have it. I'm really sorry to tell you like that. And I'm really sorry if I told you this news. And I really understand it's maybe a shock for you.
Please tell me that. Do we have any treatment for that? I'm really in a stressful situation now.
Of course, I have to inform my consultant about this condition, and I will arrange an appointment for you with my consultant so they can discuss with you the various options. Sometimes there will be but a specialized doctor can do for you a surgery for that. We can remove this septum, but we need to do another scan. It's called MRI, so we can check the extent of that muscle barrier or that extent of that what we are calling at the septum. So it can give us more idea about the extension of it at what can be done at the next. I cannot promise you about something at a moment because more investigation need to be done. And after that, my consultant, we can discuss with you the various options that can be done.
But would it be a surgery?
If the septum is small septum and not extending up to the womb, sometimes a surgery can be done to removal for this septum, and after that you will need to do some using some what we are calling as a dilator to help the area to be open and with different sizes, and then you can try to enjoy your intercourse. Am I clear so far?
I understand, doctor. When would you plan that, please? I'm really in a really in a hurry.
I really understand that, and I will try to arrange this as soon as possible with my consultant. And also, I will arrange an appointment for you with the fertility center, so you can check also the other options for you. I'm really sorry to be aware of such news for you. I will give you now patient information leaflet, and I will arrange an appointment for you as soon as possible with my consultant. Anything else you want to ask about, Amanda?
No, thank you very much. I understand that, doctor. When do I need to come next?
When you will come next for?
I mean, for the management, you said?
As soon as possible. I told you I will arrange appointment for you with my consultant, so you can come and discuss with him, and I will arrange an appointment for the scan, the MRI scan, so we can check, as I told you, about this septum. And maybe we will need to do another scan for you also to check if you have any problem in your kidney, because sometimes if there is problems in like septum or something blocking the frontal passage, maybe it will be associated with other kidney problems. Am I clear, Amanda?
Yeah, thank you very much, doctor.
Welcome. Anything else you want to ask about?
No, that's okay. Yeah, I got it, Claire. Thank you.
Thank you.
All right. So how was the station, Dua? You understood somewhere in the middle that it had to be a breaking bad news, right?
Yeah. At the end, at the end, I understand.
Yeah,
that.
so I was getting this point that you didn't do the BBN, but after that you did everything. Like, you know, it has come as a shock, and you know, you're feeling
Yeah,
that, oh my God,
it
I
comes
missed
as a shock for me. What is this? What I have to say?
So I understood that point, but that was being wise from your side, that you understood that, oh, I had to do the BBN, but now I have to cover it up. Yeah.
Yeah.
So you tried to cover it up. Okay, very well done. So yes, friends, how was Dua station? I was trying to give all the clues that please don't go towards vaginismus. It's a vaginal septum. In exam, the examination was not given, but it is very important to pinpoint that what is the difference between vaginismus and what's the difference between septum. So it is very clear description that in vaginismus, she's scared, she has pain. Here, she has pleasure, but there is some sort of a barrier. There, it is going to be very painful. So these points you need to be very clear about, that what are those things which go towards the vaginismus side? What are those things which go towards the vaginal septum side? Very well done, Dua. So to start with, start your communication with Amanda. That was all right. You did offer me support when I was anxious in the beginning. You did the patient safety in ensuring confidentiality, because that was a little personal aspect you're discussing in the consultation. I'm sorry that you're in a difficult situation. You asked about my periods, about the discharge, about the pain, about the waterworks, about the bowel, about the smear, that it was not done. That was again a very positive point. Medical surgical history, about the family history, allergy. You did appreciate that I am cutting down on smoking, and you confirmed the name and the NHS number on the reports. You did tell me about the scan report, though I was expecting a BBN, but you tried to cover it up. And you did examine me. I told you that it's a vaginal septum. Even if the examiner doesn't tell you in exam, please say that the most probable diagnosis according to the history which you're providing us is the vaginal septum, okay? So then you did do the MRI, though I would say it as a specialized imaging to see the site of the blockade, okay? So specialized imaging to see the site of the blockade. So now coming to the points to improve, I've got a little here. I wanted you to be very clear in the history taking once you asked a question about the child sexual abuse. So that gave me a clue that there is a little confusion between the vaginismus and the vaginal septum. So I gave you a very clear clue that no, it's not something like that, doctor. I'm enjoying the act. It's only that the act is not happening and the deep sex is not happening. So I was, as a role player helps you in exam. That gives you a clue that it's going towards the vaginismus side or it's going towards the vaginal septum side. One thing which I would like to ask all of you, what is the cutoff of day 21 progesterone for ovulation, please?
I think 30, Dr. Seder.
Agreed. 24 means no ovulation?
No, it means there's ovulation, but I don't know how to interpret it actually, because what I know is 30 is there's ovulation. Less than 3, no ovulation. In between, I don't know.
Less than what?
Less than 3, I think.
Yeah.
No ovulation.
So see, about 25 to 30. Different labs, they have different values. They say from 25 to 30, that is, it's ovulating. So day 21, progesterone 24. Again, you can take it like, rather than this, I would not comment that you're not ovulating. You simply say, you're going to repeat that again. However, taking your history into account that you have got healthy, normal cycles in time. You never had a problem with this. So this investigation, I won't say is an abnormal. What I would say is that we are going to recheck again. But today, the problem is not about ovulation. Today, the problem is about the track. Okay, so around 25 report, we can take it as a normal report. Okay, interpreting as normal report, provided FSH LH also supports that. So it's a fine FSH LH for an ovulation. It's a fine FSH LH. So I would say that your investigation reports, the hormonal reports are normal. However, the concern is regarding the TBS, which you just came to, that what is going to be the problem in the track. Okay, so won't be saying abnormal because it would open up another discussion point. Oh my God, doctor, that means my ovaries are not normal as well. So I would avoid that thing when I know that it's a total about intercourse stuff, that it's a vaginal septum. You get my point, Dua? So don't open up another agenda for discussion in the 10 minutes where you cannot even control the first agenda. So you've got one agenda, try to cover it up in exam rather than opening up another agenda that we are going to check the ovaries for the normal egg release as well. Okay. Now, BBN is something which you have to do before telling about this thing. And then after this, yes, your post, the discussion of the post-vaginal septum, telling me about the diagnosis was correct, and I was comfortable that you're understanding that it's a difficult situation. It has to be a team of doctors, okay? The team of doctors who take care of this condition. MDT, I wanted to listen. And 2 more points. What did I say when Dr. Sujata was doing the tubal pregnancy, tubal subfertility? What did I tell her? That in the end, what 2 options we have to mention always in the subfertility module?
Adoption and IVF.
Very well done. IVF first and then adoption. Okay, so you would say that if at all the surgery is not successful, we always have the option of the testy baby, that is the egg, your egg is going to be taken, and it's going to meet up with the partner's sperm, and once the baby is formed, is going to transfer and get attached to your womb. We call it as the IVF. If nothing works for couples, in the end, we've got the last resort as adoption as well. This line is always part of your applied clinical knowledge. Okay.
But I think here, Dr. Seda, it's better to offer her surrogacy and adoption, because if it's complete septum, how we can do embryo transfer for IVF?
After surgery.
If she did surgery, okay.
Yeah, after surgery. After surgery, at times, because of the restenosis, the intercourse, and because of the ascending problem, there might not be a spontaneous pregnancy. So then, of course, IVF can be done. Surgery is must, like septum has to be removed. That is mandatory. But after that, if she doesn't conceive, so we don't give that 100% reassurance that, yes, you're going to conceive, right? If she doesn't conceive, we've got other options as well. Okay?
Okay.
All right. Okay. So these were the points which I wanted to add. Now, a little sensitivity I would like to add in the station from the very beginning, and that is regarding the sexual history. Now, my few questions, what was her name? She was Amanda, right? Okay. My few questions, Amanda, during the talk might sound personal, but I have to know to formulate a better management plan. We as a team are here to help you with a problem. Are you comfortable to talk to me? So a very good thing Dua did, that she did not say that you've got a problem with the intercourse. She said, did you people notice what agenda did she make? She made an agenda that you are planning a baby and you're having some trouble in that. Did you people notice, all of you? That is a perfect way.
Yes.
Never make an agenda with the sexual intercourse problem at the top of the station where you're meeting the patient just in 1 or 2 minutes time. Okay, so always give a comfort zone for her to come up with her problem. And the beautiful line Dua said, may I know the problem in your own words? So yeah, that was the easiest thing which you ask for, and let the patient be very comfortable talking to you. Now, as soon as we go with the station, I'll tell you a few words which I wanted to hear, as I was like a little worried that why is this septum and I'm having regular periods. So communication with the patient and relatives, that is okay. Your greeting was fine, Dua. I'm always happy. I still remember your sickle cell disease station, in which I was very happy in your presentation. You always have a composed voice and smoothness in your tone. You can use a visual tone, a visual aid. Why? Because the septum, like you draw a vagina and you say that these can be the 3 sides. I'll just tell you in a bit. And you did check my understanding. You didn't use any jargons. I would like you to tell the pros and cons of each option, and yes, supporting me in my decision. Regarding the coital history, how is the frequency? Any problem with the intercourse? Relationship, since when I'm sexually active, I told you from the start I'm having this problem, my partner is fine. You did confirm all the other history template, that was all right. The investigations, no. Ultrasound was the abdominal one. The TVS could not be done. And it is also that we can do a tube test. This tube test also gives the outline of the tract and the specialized imaging, which is going to tell us about the site of the blockade. A very sensitive history taking should be there. Never take a general tone for the sexual history. Please keep a note. Always offer empathy on these aspects because these are very sensitive. If she's talking to you about the personal aspects, so give her a comfort zone on this. It was a correct diagnosis, but it has to be an MDT, an evidence-based management plan. So how do you say that the vaginal septum, Amanda? It's a condition in which there's a wall of tissue running horizontally across the vagina, and this wall creates blockade in the vagina. At times, there are tiny perforations naturally in the wall of the tissue that allows the menstrual blood to flow out of the body. Now, if I tell you about the position, there can be 3 positions. It can be in the lower down. The vaginal length is around 9 to 10 centimeter, and it can be at the top of the vagina in the middle, or the septum can be at the lower part of the vagina as well. Now, generally, Amanda, this is present at birth, and these 2 parts, which normally fuse together to create the vagina, they don't join properly during the development of the womb. The team of doctors, including the gynecologist, the plastic surgeon, the fertility specialist, and the counselor, they are going to take care of your situation. The aim we have is to make the vagina patent and restoration of your fertility. At times, once the surgery is done and this tissue wall is excised completely, there's a risk of stenosis, which occurs after the surgery. For that, we tell the patients to have the vaginal mold, and for 10 days time, they can put the dilators as well, which are used for further 2 to 3 months time so that we avoid the septum recurrence or the stenosis of the vaginal opening. Am I clear so far? Now, this removal of the septum that can be through the camera, putting from the below down through the vagina, or it can be through the keyhole surgery as well. Again, we are going to put a tampon-shaped object, we call it as a dilator, following the surgery to keep the patency of the vagina. If nothing works for these patients, Amanda, we always have an option of the assisted reproduction, that is the test tube baby, and as a last resort, adoption as well. Am I clear about the options available? Would you like me to repeat anything for you? I'm here to answer all your concerns. So now you have dealt with the applied clinical knowledge in a sequence. Okay, so generally you should be knowing that the lower and the middle septal defects, they've got a very good result. However, the upper septal defects, they have a little difficulty because removal is a problem, and then following that, stenosis is also a problem. So middle and the lower one, they've got a good result as an outline of the applied clinical knowledge. Remember, introduction, agenda, information gathering, explaining the diagnosis, go with the stepwise management plan, starting with the team of doctors, please, address the concerns, mutually agreed plan, and coming up with a follow-up. Patient safety was good. Communication with the patient, I was very happy. I will give 1.5 just for deduction a few score for the breaking bad news. Apply clinical knowledge, just explain everything stepwise, and in the end, IVF and the adoption as well. So again, 1, patient safety and the information gathering was correct, and I was happy about that. I was complete and 2 by 2 in those 2 domains. So 2 domains borderline and 2 domains passing. Very well done, Dua. Keep going, my dear. Any questions regarding the vaginal septum, please? Anything which is not clear, I'm here to answer.
Dr. Sidra,
yes,
just now, before the session ended, you're asking about the follow-up, when is the next follow-up will be. So
actually,
any
I wanted to tell her, actually what I wanted to know was that you're saying that today it's just going to be a consultation. So you should be knowing that now it's going to be a team of doctors decision planning for the surgery for you, and my consultant's going to plan. So we'll see you in few days time. Okay, so I wanted her to know that we are worried about this. It's not that we are just leaving you for an elective surgery. We're going to see you in a few days' time. Okay. All right. Thank you. Thank you very much, Dr. Sabia. Thank you very much for lovely pair of hearts. I always need that from my students. Thank you. Okay. So why is Dr. Yes,
Dr.
Dr.
Sidra, one
Yes, Dr.
doubt.
Sabia. Please, Dr.
How do we know that it is transverse? Because why is she getting periods? Can it be longitudinal septum?
Okay, so there are 2 points which support transverse. Remember that in transverse septum, the problem is that there's a barrier, and the penis, it doesn't go inside when you're talking about the intercourse, right? In longitudinal, it is basically felt that the space is there and the space is narrowed down. So the chances is that even if it's not an if the erection isn't very strong, the chances is that insertion would be there. That's number one. Number two, remember that the subfertility occurs with transverse, and the longitudinal doesn't have a problem if at all ejaculation is done. The ascent is fine because it is connected to the womb, that is the uterus. So it's the transverse septum which causes the subfertility. The longitudinal, if the connection even of one of the path is there, so basically the ascent of the ejaculate is there. Okay. The third thing important is that in longitudinal, you're absolutely right. There would be normal periods. In transverse, in perforation of the septum, there are tiny holes in the perforation of the septum, and that can have a normal period as well. Okay.
Okay.
Thank you very much. Thank you. So again, as Dua said, that we are going to have another imaging. So the specialized imaging to see the site of the defect, you can add on into that, Dr. Sujata, is going to be an additional point, that we are going to do specialized imaging to see the site of the defect, or what specifically is the type of the defect or the blockade. Okay, so that will be fine. This is what tells you the MRI. Okay. All right, thank you.
Dr. Seda, please, one question again. Here, no rule for the kidney abnormality, because this is not Maloyan agenesis. Am I correct? Because I remember I mentioned in the in my case that I want to rule out if there's any kidney problem. Here, it's not a Mullerian agenesis, so no need to mention that point that we have to do another scan to check your kidney and your.
Not Mullerian agenesis. We already proved that in the androgen insensitivity and in the MRKH. Why? Yes. Because when the uterus is not formed, at times the ureter or the kidney abnormalities are there.
Okay. Okay, Dr. Sam. Thank you.
Thank you very much, my dear. Thank you. So, thank you very much for a wonderful station, Dua. We are going to do Dr. Sabiha's station now, but I would not like to do the structured discussion with Dr. Sabiha because what I made for you guys, that's all up and down now. So let's go to the SPT. Hello, Dr. Sabiha. How are you doing?
Hello, assalamu alaikum.
Walaikum assalam. Long time. How are you?
Yeah, long time. Actually, I was not feeling well. Even during the first session, I was sleeping. Anyway, alhamdulillah, now I'm fine. I have taken, just yani, some flu and some headache. We are, anyway, alhamdulillah, right now I'm okay. I can do the station.
Please take a little Panadol and rest more. No stress at all. So gradually we have to pump each other, encourage each other, because we have to pass the exam. Yeah?
Yeah, inshallah. Inshallah, if we have a chance,
inshallah. Yes, that's like my Dr. Sabia. Yeah? Okay. Inshallah. Right. So starting with the station number 4. And it appears as 5 because I have skipped the structured discussion. So let's do the 2 minutes time. It's an easy station, Dr. Sabia. Just a signposting. Why easy station? Because this management you do every day in your gynae clinic. So please take it the way you do your patients. Go ahead, please. Thank you.
Next slide. This is the last slide.
Yes, Doctor.
Okay.
Start, please.
Okay. Hello, I am Dr. Sabia, one of the doctor in the fertility clinic today. May I confirm your name and age, please?
Yes, sir. Hi, doctor. Doctor, I'm Sarah Michael. I'm 28 years.
Okay. Is it okay if I call you Sarah?
Yes, please.
Sarah, I can understand from your notes that you are having a complaint of irregular periods, and there are some abnormal hair growth, and you are already diagnosed as a polycystic ovarian syndrome. Am I right?
Yeah, exactly, doctor. My main concern is that I want a baby. I just want my treatment for that.
I can understand your concern. Sure, I will be discussing your management options. But before that, I would like to ask few questions to know more about you. Is that okay?
Yeah, that's okay.
Okay. So, Sarah, can you tell me more about your periods?
Doctor, it's been long. I mean, till my teens, since my teens, I remember that I never had regular periods. I don't know exact date. Maybe at times they're after 30 days, at times they're after 35, and at times they're after 60 days as well. So no fixed cycle I ever had. Along with that, I've got growth of here on my face, on my cheeks. Here you can see, but I had been getting treatment for that. That's not an issue. I always had been working on my weight. It's always on the higher side. But now the
Mhm.
problem is that I'm into a fresh relationship and I'm desperate to have a baby. So all these things I'm being treated for in the gynae clinic. Actually, I want to know that what you can do for me to have a baby. I'm ready for all sorts of management plan, whatever you decide best for me, doctor.
I'm really sorry, Sarah. You are having this issue. Sure, we are here to help you to sort out the management options for you. I can see your weight on the little higher side. So, of course, sure, we will work on it. Can you tell me, is there any other medical issue or condition for which you are going to your
No,
GP?
no,
Any surgery done on your tummy and down below?
no, doctor.
So, are you with someone right now in a relationship?
Uh, yeah, I told you that I've started a new relationship and now my partner desperately wants a kid.
Okay. So, so a few personal questions, Sarah. Is there any problem during sexual intercourse?
Not at all. We enjoy that a lot.
That's good. Um, do you have any allergy?
No.
And who supports you, Sarah?
Uh, yeah, actually, my partner is earning as well. I'm also an engineer, so that's not a problem. Everything is fine.
Okay. Okay. Do you take alcohol or do you smoke or any other recreational drug?
And no,
Okay. And what about your partner, Sarah? What's
what do you
his
want to know?
age?
Yeah, he's of my age, maybe 30 years, a little elder.
What he do?
Yeah, he works in his office. He's also an engineer.
hmm And whether he has fathered before?
Yes, he's got one kid from the previous relation.
Okay. So, Sarah, I would like to, Yani, and his investigations done so far?
He doesn't require, everything is fine. He just had a kid 2 years back and he's healthy otherwise.
Okay. So, Sarah, I would like to do some examination in the presence of chaperone with your consent. Is that okay
Please.
with you?
Yeah, that's fine.
Okay. Uh, Sarah, after all investigations and examination, and as you see, you are already diagnosed as a polycystic ovarian syndrome. Do you know about that condition?
Yeah, it's been around 10 years, doctor. I know everything about that. What I need to know is that how can I get pregnant?
Okay, Sarah. So, Sarah, there are few options for you, because in this condition we call polycystic ovarian syndrome, there is the problem of releasing egg from your from your ovary. Okay, see, I can draw for you. This is an ovary, and in such situation, in this condition, there are follicles which are not releasing egg, and there are more follicles towards the periphery of the ovary. Am I clear, Sarah?
Yeah, that's okay. So how can you help me with that?
Yes, we can. There is options of giving some medication so that your egg can release from the follicles of in the ovary. So there are some tablets we can give. There is a tablet named clomiphene. We will start you this tablet from the first or second day of your cycle for the 5 days, and during the first cycle we will monitor that whether you are releasing the egg or not, by doing this mid-cycle serum, one of the hormone on day 21, progesterone. And as you have a prolonged cycle, so we will decide which day, or we will do then in that situation from 21 day every week. We will be monitoring this hormones, and we will continue these tablets for like 6 months. And if you are not yani ovulation done, then we will continue more further 6 months. If you don't conceive,
sorry, doctor, that means that 1 year I need to take it.
No, Sarah, if your egg is released by taking this tablet, then we will keep you on this tablet, then that dose, because we are giving that tablet with the increasing dose. From for example, we will start 50 milligram, then we will continue till your egg is released, and that the dose which on which your egg is released, we will continue for at least 6 months.
How much dose would you give me to start with, and maximum?
Maximum we can give you 100 milligram.
Okay, right. Okay, and to start with
50 milligram. We will start 50 milligram.
I get that. All right. So I'm going to take that every month?
Yes, every month. Yes, every month. For 5 days from second day of your cycle.
Okay. Then?
And we will monitor your follicles by ultrasound.
Okay.
And if you, for example, if you not your egg is not released by taking these tablets, we have another options. We have 3 options, because as you are already taking metformin, so no need to wait for taking another medication. Just you have 3 options after that. If you don't ovulate by taking clomiphene citrate, we can give you injections. We call it gonadotrophins, or we can you can go ahead laparoscopic ovarian derailing. Do you know about that?
No, I don't know anything about that.
So what we do by laparoscopic ovarian drilling, with the help of a camera, we will put a small camera in your belly button after putting you sleep. Then a small puncture is done in these follicles. And by doing this, what happens, as your hormone, as you are having this abnormal hair growth on your face and all, it's because of the some of the hormones released by these multiple follicles. These hormones are going down, and ovulation happens because ovary response increases after this small puncture in your follicles in the ovaries.
Okay.
Am I clear so far?
Yes, I got that, doctor. So for how long you're going to try the clomiphene, and then you're going to go with this keyhole surgery or something?
We will give you this clomiphene if you don't ovulate. For example, for the 3 cycles you don't ovulate, like your egg is not released, then we can go ahead with these options.
For how long are you going to wait?
3 cycles. We will wait for 3 cycles. If you don't ovulate for 3 months.
I see. All right. Okay, doctor. So shall I start with this clomiphene from today?
Before taking this clomiphene, as Sarah, you are having your weight is on the higher sides. What we what we can do, you can go. I'm giving you a referral to a dietitian, appointment with a dietitian to manage your weight. Because if you decrease weight on your own side, then it also beneficial for you. So before starting clomiphene, what you have to do to low down your weight.
Okay, doctor. So for that, can you help me with something?
Yeah, I am giving you appointment with the dietitian, and you can go with some of the exercises or some of the yani. Then if you decrease your weight, then it will be beneficial for you. Sometimes it helps a lot.
Yes, yes, I understand the doctor. Thank you very much, doctor.
Thank you. So these are the written information for you. And I'm putting another appointment with my consultant and with the dietitian.
Thank you very much,
Sarah.
doctor. Thank you. Yes, Dr. Sabiha, how is polycystic ovarian syndrome?
I'm sorry, Dr. Sidra, it's very bad. It's very bad. I did it very bad even.
However, you made your 100% trial to make a pickle out of the applied clinical knowledge of 3 and 6 months, you know.
A long time, I did not read even a single word.
I understand. So, Dr. Sabiha, every time whenever I come online, you know, I listen to the same thing. In the first 2 days after the session, you're active in the mini group, and then again you vanish. So, you know, every time
I'm not studying at all. Yani I can see now the 1 year,
Dr. Sabiha,
almost a year.
Dr. Sabiha, your Yenny tells me during the station that you're not studying at all, you're not practicing at all. 4 Yennies in the station. Dr. Atiya, are you there?
Not even practicing. Yes, not even. I'm not touching even the books, anything. So for that reason, I am avoiding to do the stations because Yani I'm not, you know, I can tell you.
Okay, relax. No problem. No problem. The first most important thing is health. And once you get better, then definitely you know, we are going to be very strict. I'm just waiting that, you know, the college opens the registration. And I would be so strict with you guys that everything would be secondary. Till that time, actually, I'm a little lenient for the reason that we don't know. I screw you guys up, and you know, again, the registrations, they are not like if people don't get the seat. So then it's going to be like on my part, it would be a little difficult to handle you guys. I'm just waiting for this thing that you people have these, you know, registrations, and then I'm going to be very strict with you guys. So, Dr. Sabiha, many good points were there. Harshaba, please, yes, I am serious about this. The reason is that whatever you people had been doing, you'll forget everything. You've got 4 books to cover, my dear. People, my July and April batch, they've completed their Kunje as well. They've completed their Lisa Joel, Tony, only few stations of Oxford. I kept purposely Oxford in the end because I know that this is something which people have done already. So all the new books, now the Kunje has also been completed in that group, you know. So now I know that April and July batch, they've done all the recall stations, they've done all the exam stations with the keys, they've done all the books. So I'm not worried about them. Now everything, their folders are ready. So of course, you know, for you guys, I'm worried because we have to open up books, we have to make templates of each, we have to be ready in that sense as well.
I appreciate the girls which are doing the stations and they are continuously studying. I really appreciate because I don't know. It's difficult, yeah. I don't know how.
But see, Dr. Sabiha, in the current batch, in the February batch, I got like 25 registrations. All of them are repeaters, and see, they're ready. They want twice a week session. And I was worried. I was telling them that please let's make it once a week. No, we are going to do it twice a week so that we finish up in 6 weeks' time. Still, they are not sure. But these are some names like, and for the first time in the 25 batch, I've got 7 boys. And believe me, those 7 are, all of them are so enthusiastic. 3 of them are Malaysians. And I was making a schedule for them. They said, no, we are going to, no matter you take at 8 a.m. GMT, but we are going to do 2 sessions a week. So that means that, you know, people, I take you guys as a whole. People are really working hard because they know that this is now actually difficult to get seat again and again. So we have to do that. And I'm sure, Dr. Sabiha, you've got all the potential. It's not only with you. I know every batch, like you'd see, Divya is not here today. Divya was so active. Because of course, when the registration is not there, you don't have the goal in front. And I can understand one tends to get a little, low because of this, that we don't have any date in front. What is the target we are achieving? So don't worry about that. I'm sure with passage of time, yes, Dr. Sabi, I'm sure you will do that. The most important thing is health. Please get well soon, get better, and then definitely we're going to do that together. Okay, I'm not going to leave you, and we are going to practice more and more. I'm sure you'll be better.
Inshallah, I will. When I will start, I will do definitely.
Very well, very well.
Inshallah.
So I know you from part 2, and I know your skills. When you take a lead, you screw everybody, and I know you that when you plan for yourself that yes, I have to pass. You know it. You have got that tendency. The only thing is that motivation is lacking at the moment. Am I right?
Yeah, you are right. When I think that I will do it,
I
will do by hook, by crook.
Yes.
I will do it.
I know with your age, the way you just took my, part 2 students together, sitting together, doing the recalls, all the EMQs has been, and I was astonished that, in that age group, you're still so active, mashallah, because at that time you had this motivation, I have to pass in one go. And I know you that once you'll make a plan, you will fulfill that, and you have all the potential to do that. You're not less than anyone, but the only thing is that now the plan is not made yet. So I'm waiting for that day when you think and you make a plan.
And
so
my group is also suffering because of me, because I'm not active, so they are not active.
I know. I totally understand. It's a group effort. And I know Abir has been trying a lot. And she keeps on, sending messages. And
yeah.
So you people have to coordinate with each other, please. Sarwat, if you're listening to me, I know you're busy in the duty, in the recording. If you're listening to me, please. Just pull up everyone. Dr. Atiya, I know your skills. Don't worry, please. Try to pull up everyone, because it's going to be, in the end, you guys. I want that there is no picking up of the OSCE books again after this May. So you all have to pass for me, okay? And I'm all here to help you guys. More and more new students are coming for me, but you people have your own place. I have my responsibility that you people pass as a batch. I have my own assessment for this, that how much I had given an input. I just want the output from your side. And I'm sure you people would do that. I have faith in you guys, and I know your potential. Okay?
Dr. Sidra, tell me one thing.
Yes, please.
Tell me one thing only. Do you think still that there will be in May, there will be any chance given to the international candidates?
See, I'll tell you. No matter they give 30 seats, 35 seats, the day they give you this email, I'll give you an example. I've got a very senior obstetrician, my student of MRCPI, and he is one of the leading obstetricians in the capital. He could not study because he had to go back from Saudi to Egypt because of some family circumstances. He could not get application for the last September exam MRCPI Part 2 written. He received it yesterday in the morning, and now there are just 30 days, 35 days before the exam. And he messaged me, Sidra, I wish they accepted me last time. Now I'm not ready. Now, I don't want this situation with you guys. I know there would be less. I know 100% people who would be registering would not get the seat. But if you get the seat and you miss it, that would be our failure. Because see, the next time it's going to be again a backlog. So we don't have to think whether we get the seat or not.
Dr. Sidra, return is different.
Has to be.
Return is different. No, OSCE clinical is Yani.
Dr. Sabia, no Yani now, okay? It will become your habit. All right, no Yani. All right.
Okay.
So what I mean to say is, Dr. Sabia, what I mean to say is,
Sujata is very optimistic.
Yeah,
I want Sujata. I want to be optimistic like Sujata.
Dr. Sujata, please do me a favor. After the session, call Dr. Sabia and do 30 minutes counseling for me. Dr. Sujata, you have to call Dr. Sabia after the session and 30 minutes talk. Please tell her that it is so shocking. You know what is Liana saying, Dr. Sabia? Please see the chat box. Liana is saying, what is Yani?
Yani.
Tell her, please, what is Yani? Liana, I cannot tell you. Dr. Sabia is going to tell you. Dr. Sabia, please tell her, what is Yani?
Yani is a Urdu word that means meaning. That means. It means Yani. It's a Urdu word.
Liana, don't worry. This is something like this is something that she wants to emphasize on the fact that I mean. Okay, so when you say that, Sarah, I mean by saying this is So this is when she takes the histories of the Saudi patients. They're in habit of, the Arabic people, they're lots in habit of saying this. So I can see that where she works, actually that becomes a habit. And it's not only Dr. Sabia. All my students working in Gulf and working in Saudi, they have this tendency, they say yani a lot, because this is how they talk to their patients. Yeah. So don't worry, this is something like it means. Okay, it's an alternative of it means. So Liana was thinking that I'm missing out at some something.
Liana is very enthusiastic to know each and everything.
No, of course, because she was thinking that I'm missing out some layman dictionary. Actually, the patient information. We played Liana. Okay, let's come back to the feedback, friends. Okay, so there were certain good points. Introduction was fine. Dr. Sabia, please go back to the station and the recording. Your first 2 minutes, you had a very composed voice. When it came somewhere in between at the question I've written about the history, the medical history, the surgical history, the voice went slower. So the confidence was at the peak from the start. It was a very smooth start, but confidence was going down with the passage of station, which I don't want. The voice should remain the same. It should keep, this is the same tone, yeah? So information gathering was fine. You did offer me support in the beginning that, yes, I'm having this trouble. I tried to give you a clue. Please don't manage me for irregular periods. Don't manage me for hirsute. I am knowing what polycystic is. Please manage only my fertility aspect, because otherwise polycystic ovarian syndrome is a big station. If the role player doesn't give you a direction, of course, you have to manage everything. So my fertility concern was the basic thing which you tried to manage. That was good. So then you came up with the medical, surgical, personal history. You did give me the explanation about what happens in the polycystic ovarian syndrome, why the eggs are not being released. You did tell me that multiple eggs are formed, and however, they're not healthy or the good quality eggs to have a meetup with the sperm to form a baby. And you offered me clomiphene. That was the correct choice of drug to start with. And then you did say that you're going to do ultrasound to see whether the egg release is there. You did offer me 3 alternatives, but I wanted that a little clarification. The 3 months, 6 months, 12 months, all was a little jumbled up in the station. I'll tell you in a bit that what you have to speak. We are not going to give clomiphene citrate, friends, more than 6 months time. Remember, that is the maximum which we can give to the patient. And then BMI was 39 in the end. You were correct that today we are not ready to start with the clomiphene. We need to come into a healthy shape of health before getting pregnant, because that is important for a healthy pregnancy outcome as well. Now, certain points to improve. Whenever patient has something, Dr. Sabia and all of you out there, whenever patient has something, it's better to, rather than saying that you have polycystic ovarian syndrome or you have diabetes or you have sickle cell disease, it's always better to say that you have a condition. Okay, so that is a little mild form of saying that she is not polycystic ovarian syndrome. This is the condition which she is having. So that is a nice way of saying. So once you said in the agenda that I've gathered that you've got irregular periods, you've got hair growth as well, and that you're known to have polycystic ovarian syndrome. So rather than that, I would make a crisp agenda. If you see here that she's in the fertility clinic, okay? So she's in the fertility clinic. So if you make an agenda, rather than saying that you have polycystic ovarian syndrome, you can say that you're having a condition. The word condition tends to make it smooth to absorb from the patient's perspective. Please keep a note, all of you. Always, whenever there's some disorder, there's some disease, try to say that it is a condition. Okay. Now, the second thing is that you did ask about the partner. However, test. So in history, I would like to say, is your partner generally fit and well? So this one word I would like to know. You did ask about, did he father any child before, right? So that was good. Okay, there was one statement which was about profession, about the partner. So the statement was what he do. So with he, we put a does. So we are going to rephrase that, Dr. Sabia, together. So may I know, what does your partner do, or what he does for living? Okay, so this is how we are going to make this statement, though it's just rephrasing, otherwise it doesn't make any difference. Okay, so at the point of the medical history, surgical history, the voice was going down, down, down. So this voice, I don't want to go down during the station. It should always maintain the tone. Don't get underconfident during the station. With passage of time, the confidence should be on a rise. Confidence should be on a rise. Now, rather than saying the word follicle, okay, rather than saying a follicle, we would say the eggs. Multiple eggs are produced, Sarah. However, the good quality eggs are not released from the ovary. And that is the reason that the couple tends to have difficulty in having a pregnancy. Okay, so follicle word is a jargon. These are eggs of not a good quality eggs. Multiple eggs are being produced which are not of good quality to have a healthy pregnancy. This is what we have to replace the follicles word with. Now, ovulation was used 3 or 4 times. No problem, Dr. Sabir, it wasn't bad at all. We have to just concentrate on the good points to make our strength and work on the tiny points which we have to improve. And I know that you can do it. No problem at all. Okay. So about this aspect of ovulation, the word which you have to use is egg release. Okay, ovulation is a jargon. You say egg release. Now, the maximum dose which you said was 100 milligram. An applied clinical knowledge just to tell you that it's 150 milligram, okay? Starting from 50 and we can go up till 150 milligram. And then I've written no yani in the station, please. 3 times it was used. So try to be more smooth as per the patient talk. And with practice, definitely this would be reduced. You did offer me dietitian for a connection for the BMI, reducing BMI, and that was really good. I was happy on that. I would tell you guys about the applied clinical knowledge in the algorithm which I've made for you guys. So before that, can somebody tell me what is the difference between clomiphene resistance and clomiphene failure? Yes, please. Clomiphene resistance and clomiphene failure. Any bright mind is gonna tell me
Clomiphene resistance. Clomiphene resistance is that the ovary does not ovulate. And clomiphene failure means that it ovulates but not get pregnant.
And
what I know.
Yeah, you are absolutely right. So
Not,
what did you?
Yani it doesn't get pregnant.
Okay. So please tell me, what is the management plan in both conditions?
Clomiphene resistance means she needs something else like gonadotrophins or laparoscopic ovarian drilling. And clomiphene failure also we try, yani if she don't get pregnant, we.
No, yani, Dr. Sabir. Yes.
No, okay.
Clomiphene
failure. The management is same, yani people. I'm sorry. Management is same. We try all the people who are doing IVF. Yeah, someone wrote IVF. We can go ahead with IVF if there is ovulation, there is egg release, and she's not getting pregnant. So we have to check other parameters like the tubes are patent. If all the parameters others are normal and she is having ovulation there, then of course we can go ahead IVF.
Always IVF, remember. That's the difference which I wanted you to be very clear at, and I'm going to give you lines on this, okay? That applied clinical knowledge should be perfect, spot on. It should touch the heart of the examiner that this patient, because the polycystic ovarian syndrome is something, if you don't know polycystic ovarian syndrome, they would be very strict on this. Applied clinical knowledge of polycystic ovarian syndrome is something which is mandatory to know, because it's a very common station, something which is you encounter in your gynecology clinic, in your fertility clinic very frequently. Yes. So communication with the patients and relatives, your greeting was fine. You're starting. I liked your starting today. Somewhere in the middle, you had lost your confidence, but you did support me in my decision. That was very good. You did ask about my menstrual history, about my relationship history, about the coital history, the gynae history, the obstetric history. I never had a pregnancy before. Medical history. You can ask about the ruling out about the raised blood sugar levels, the diabetes. Why? Because we know that it is related to that. You knew about my BMI, smoking, alcohol, support, mental health. You did examine me. That was all good points. You did address my concerns that I want a baby. That's my basic concern. And this is going to be being open and honest about the long-term health implications. If she asks about that, it's going to be a team of doctors. Let's begin. So what was her name? Sarah. Sarah, as you're aware of this condition, the polycystic ovarian syndrome, I would like to suggest at the very beginning that before starting with the treatment of the egg release, we suggest the patients to have in the healthy BMI range, reason being that if the BMI is more than 30, the chances of complications during the pregnancy is also higher, and the risks of the pregnancy loss is also on a rise for these patients. Once you get into the healthy BMI range, I'm going to connect you to the dietitian and the exercise specialist for that. And once you get into the healthy BMI range, we are going to plan the egg release medications for you. We call it as clomiphene citrate, which can be used alone or with a combination of metformin, keeping in mind the higher BMI, it is going to be effective. Just telling you for your information that at times with metformin, patients, they have sickness, vomiting, some tummy upset can also be there. Now there are two situations which I would like to discuss with you, Sarah. So starting these medication, we call it as clomiphene, we can give that for the maximum of 6 months. We begin it at the day 2 of your periods and with 50 milligram dose, and with subsequent cycle, if the egg release is not there, we can double it up to 100 milligram or maximum 150 milligram for 5 days from day 2 to day 6 of your cycle. Now we can encounter two types of situation. After the hormonal check or the ultrasound, Sarah, if we see that egg is not being released with this clomiphene, and we have tried it for the maximum 6 months time, we call the situation as the ovaries being resistant to the clomiphene, and we go to the other alternatives. One is the keyhole surgery, Sarah, in which we trigger and do the puncture in the ovaries for the stimulation of the egg release. Other is that we give some injections called gonadotrophins, or for that matter, if less than 6 months was the use of the clomiphene, we can add metformin in the second point as well. Now, if the ultrasound tells us, Sarah, that the egg release is done after the release of, after the use of the clomiphene, that means that there is the lack of egg release after using of clomiphene, we call it as a failure of the drug. In that situation, the team of doctors are going to decide for you. The egg of your egg with the partner sperm is going to meet up in the laboratory, and once the baby is formed, is going to be placed in your womb. We call it as IVF, in vitro fertilization, Sarah. Am I clear about both the aspects after starting the treatment of clomiphene, please? This is what I wanted to hear very clearly regarding the resistance and regarding the failure. So in short words, please remember that clomiphene resistance means that ovulation is not there, so you try to plan the other ovulation techniques. But if the ovulation is there, then there's no point, because ovulation is with clomiphene citrate. Then there's no point of LOD, there's no point of gonadotrophins. Remember, the only thing which you all need to remember is that if the ovulation is there, then you treat that case as an unexplained subfertility. Am I clear? Am I clear? That is, we treat the patient as an unexplained subfertility. That means that now the ovulation is occurring, but still the patient is not getting pregnant. That means that now we need to do IVF. This is what I wanted to hear from the management aspect. Introduction agenda, information gathering, explaining the diagnosis, stepwise management plan, address the concerns. It should be a mutually agreed plan. Please tell her about the follow-up once she is in a healthy shape of health to get pregnant with a BMI into the normal standard. Yes, we are going to plan with the clomiphene citrate. Am I clear now? So no 12 months, Dr. Sabia, only 6 months. That's it. Okay. And that's 6 months.
I mix everything.
Yeah, no problem at all. No problem. Just remember this algorithm, do it from here. And this is how the management of the polycystic ovarian syndrome goes. Here, I would like to tell you all that please, polycystic ovarian syndrome, this patient was in the fertility clinic with a fertility desire. This patient can come as a gynae clinic as well with the irregular menstruation, with a hirsute. So then you're not going to talk about the clomiphene, of course. If our concern is periods regularity, so then you're going to discuss about the hormone aspect, the hirsute treatment. So that's a separate station. Polycystic can come as a gynecology station. It can come as a fertility station as well. Am I clear, everyone? Yes?
Yes.
Okay.
Yes.
Thank you very much, Dr. Sabia. Thank you, Dr. Sabia. So please do wait for Dr. Sujata's call after the session.
Inshallah.
All right. Thank you very much. Harshiba, The risk after stimulation is higher. However, today we are not starting that. So it's okay. Today we are giving a gap so that the BMI gets back to normal, right? So once you start clomiphene citrate, definitely, yes, we'll mention that. Today we are not starting clomiphene. Why? Because the BMI is way too high at the moment. Okay, thank you very much, Dr. Sujata. Give me a feedback. What does Dr. Sabir say? And I would see that how is your counseling, Dr. Sujata? I'm giving you a challenge now. Thank you very much. Okay. All right, friends. So
my God, Dr. Sabia become the challenge.
Yeah, no. The challenge of counseling you. So let's see that how much motivated you are after Dr. Sujata. All right.
Yeah,
Okay.
even it is challenge for myself.
No, I can understand, Dr. Sabia. I can understand. All right. So
Sure.
we have got, thank you very much, Dr. Sabia. Thank you very much. Always lovely listening to your voice, my dear. Thank you. All right. So Liana did the station, Sujata, Dr. Sabia, and Dua has done the station. Who do we have next? Now, for me, it's Sarwat. Sarwat has not joined yet, friends. And then again, only Liana is left. Let me see the station. Sarwat not joined yet, friends?
No, Sarvat not joined yet. I think she's busy in the duty.
Okay. So let's do with Liana then. Liana, we are back to you again.
All right.
All right.
Let's go.
Let's do with Liana. And she is doing for Harshiva. Yes. All right. Okay. So this is, I resume my share, and here goes the timer. 3, 2, 1. Let's go.
Next slides, ma'am. Do you have next slide? Sorry, Dr. Sidra. Can I have 1 more minute because I have to close the door?
No problem, please.
Hello, my name is Dr. Liana. I'm one of the doctor in the clinic today. May I confirm your name and age, please?
Yeah, hi, doctor. I'm James Wilson. I'm 45 years.
Can I call you Mr. James?
That's okay.
I believe that you are under our follow-up because you guys tried to get pregnant for the past 2 years. Is that right?
Yeah, exactly. We're planning for a baby and things are not working, doctor.
That must be difficult for you. And I believe that you are here today to discuss about all the investigations that has been carried out.
Yeah.
Based, Yeah, I have all the investigation here, but before that, in view of this is me first time meeting you, is it okay if I ask you a few questions to know more about you? And then
Sure.
after that, we can explain the result and I address the concern, and also together we formulate the management plan for you.
That's okay.
All right. So, Mr. James, do you, how I mean, you've been trying for 2 years. Okay. So, have you ever had any child before in your previous relationship?
Rephrase the question. Ask about, may I know more about your problem? Because this question would be yes or no, Liana. Okay, go ahead again.
Okay. May I know about your problem, Mr. James?
Yeah, there's no problem at all during the sex, doctor. Everything is fine. No problem with the intercourse. No problem with our sex life or our relationship. The only thing is that for the last few days, I'm feeling that I have to go for pee a little more. And other than that, I don't have any problem at all. But the things are not working. I mean, my partner, she's not getting pregnant at all.
All right. All right. So you mentioned about you peeing a lot. I mean, do you have any other difficulty? I mean, in passing urine, like pain
No
or
difficulty, no. I just felt that it is a little more than normal. Maybe it's just like my feeling.
mm-hmm. Do you have any other symptoms that are concerning you beside this increased frequency of peeing?
No,
All right. Do you have any medical problem before?
I never had any, no.
Any surgery done on you before?
No, doctor.
How about your height to weight ratio?
That's okay. That's around 25.
25. How about, do you smoke, drink, or taking any recreational drugs?
I was doing that, but now GP told me that it can affect my sperm release, so I'm just stopping that.
I appreciate that. What do you do for a living, Mr. James?
Yeah, I actually have my own online business. I work for the government's work, yeah.
All right. So, trying to conceive for 2 years, how's the support at home? How's your relationship with your wife?
Yeah, that's really good. I mean, the only thing is that we want to strengthen this relationship and we are unable to have the pregnancies. And I'm really serious about that. I'm ready for all sorts of treatment.
I see. I'm here to help and support you in this, Mr. James. So, what do you know so far about all the investigation? Do you have any idea, or anyone has explained to you regarding the results?
Not really.
All right. Can you move to next page, ma'am? All right. I have confirmed your name and Hinesh's number in your report, and all the, I mean, the semen test that we done on you. I'm sorry, it is not what we expected. It shows that there is no sperm in your semen.
Sorry, doctor, what do you mean? I mean, I don't have any problem and I really have a good fluid in ejaculate.
I see. That is why we need to investigate more, and absolutely, I will formulate a plan for you after this. Beside this semen test, we have the hormonal profile. It shows that it's at a normal level, and we also proceed with the genetic makeup test. It also normal. However, there is one test, the blood test that we took. It shows that you have newly diagnosed as diabetes. Have you ever aware of that?
No, I don't know that. Probably that's
Mm,
the reason that I was feeling a little change in my P frequency.
that may be the cause of that. Yeah. We're gonna go step by step here, Mr. James. So I would like to um, um, discuss this case with my consultant and also refer you to fertility
Sorry to
specialist.
cut you, doctor. Please tell me that what is the reason that I don't have these sperms?
Okay, there is a various reason why you don't have the sperm in your semen test. It may be because of uh, the newly diagnosed diabetes as well. It can contribute to this factor. Do you have
Hmm?
okay. Are you taking any? Sorry. By the way, are you taking any medication or
No,
anything currently?
no. I was
No.
just given some tonics by the GP and some multivitamins. That's it. I mean, I'm not taking any medication. That too, I'm very regular in that.
I see. From the investigations, I can assume that this no semen in your no sperm in your semen test because of the condition in your testicles when your testicles is not working properly, right? There is a few plan that I would suggest you. Means there is what we call as biopsy. We take some sample or some tissues from the testicles, and then we can proceed with the treatment of the IVF. I mean, yeah,
IVF?
IVF is a test tube baby. In view of your wife result is normal, so in your fertility issue may be because of this no sperm in the semen itself. So the management is for IVF, and we need to extract the sperm from your testicles. Then it's a procedure that will be done under local anesthesia, and a small needle will be inserted through the testicle to extract some tissue from it. Are you
Okay.
listening so far?
Yeah, I
Okay.
am. So, is it going to be fine? I mean, if you take the sperms out of that and then you're going to use it like for IVF, I suppose?
Yes, it is to choose the good quality of sperm to inseminate with the eggs. Beside that, I would like to optimize your diabetes control because your sugar level at the higher side. So I would like to refer you to the dietitians and would like to your GPs regarding this. It is good if you can control your sugar. It will be very good in your general health, well-being, and maybe it can improve your sperm count as well. Beside this, we will repeat the semen test as soon as possible to confirm the diagnosis as well.
When would you when would you like to repeat that?
As soon as possible. We will repeat it as soon as possible. I will write to your GP.
This is the second test.
This is the second. In that case,
Would you like to do the third one as well?
no, Mr. Jim. If it's the second test, then it is confirmed that no semen in the semen test, and we will proceed with the referral to the fertility specialist for advice and for further management, which is the IVF and the sperm extraction. Okay. There is there is an alternative, which is an injection to stimulate the sperm production, which is in your case is not needed because your hormonal profile is normal. So we know that it's not from the gland from the brain that causing this, but it's from the testicle itself. I would like to give you a patient information leaflet for your additional informations, and we'll see you back in the next appointment with my consultant. Thank you.
Thank you very much, doctor. Thank you. How was the station here?
I didn't prepare for this station. I'm so sorry.
I could guess that. I could guess that. The hormonal profile in front of you. Hello, everyone out there. Please, an open question. What is the problem in the hormonal profile? 24 and 22. What is the reason about azoospermia here? A 45 years, FSH 24, LH 22.
Testicular failure.
Thank you very much, Dr. Sabiha. Very well done. It is a testicular failure. And you have to tell, basically, the testes are failing to respond to produce the sperms. It's a problem with the production. Okay? The hormonal profile is not normal. Remember always that whenever FSH, LH goes into double figure, when it goes into the double figure, basically, they're going towards the failure aspect. Taking into consideration James' age, and the hormonal profile being 24 and 22, that goes towards the testicular failure. Okay, so that can be a reason of autoimmune because of some diabetes as well. It can be age aspect as well. Keep a note. So diagnosis wasn't fine. Remember, Liana, I totally understand that if it was not prepared, remember out of 4 days, 1 or 2 days, that the male subfertility always tends to come in exam. And I've tried to make algorithms for you guys so that whatever type of male subfertility comes in exam, you're very smooth in handling that case. Okay, so we have got many good points here as well. Communication with James was fine. You did mention in the beginning that yes, it's going to be, it's a difficult situation. You offered me support. In information gathering, sorry, I cut you there, but I didn't want to go in the wrong direction. So your first question, that did you father any child before, was a wrong question. Always ask the open question regarding person presenting complaint, okay? Why did I cut you there? Because that was the same thing I told you in OHSS as well. He is here for the subfertility aspect. So let him come with the instructions which are in the role player key, okay? Then you can ask about the fathering child, about the P, about the symptoms, about the medical history, about the surgical history, the BMI. You did ask about the occupation, support, about the female partner. You confirmed the name and the NHS number on this. You did recognize that HbA1c is raised. That was good. You did take the biopsy tissue sampling from the testes to confirm any sperms there. And the management, because we couldn't detect the problem, so the management didn't go right. But otherwise, it was the communication was fine. Patient information leaflet and the support was given. Certain points to improve. Yeah, the information gathering first question, please. Let's practice together to have it as an open question, please. I appreciate you did say about the smoking, so that was a good point. Always in history, whenever semen analysis comes, in history, please ask, may I know that this test is a repeated one or is it the first ever test? Right, Liana? That will save you from many things. You did not ask that. I did not purposely tell you that. So you have to ensure in the history. So may I know, Mr. James, was it the first test or is it a repeated one? Okay? That would make things very easy for you. So if it's the first test, you're going to say we are going to repeat that in a few days' time as soon as possible again after the abstinence from the 6th. And if it's a second one, then you confirm the diagnosis. This would be in semen analysis as well. All of you, please listen to me very carefully. This would be in premature ovarian failure as well. Am I clear? Am I clear, everyone? Always ask for a second test in the history taking if it is the first one or if it's a repeated one. Very well done. So then it's going to be, yeah, the problem occurred when you said in the interpretation that your hormone tests are normal. So you had to say that they're elevated. That shows that the testes are failing to produce the sperms. Now, when she asked about what can be the reason, how I would put it into words is that, Mr. James, I can understand the concern behind. At times, the sperms, they go the wrong way, or at times there's some tumor sitting in the testes which causes obstruction in the pathway that the sperms are not released. However, keeping your hormone in mind, in your situation, the hormone levels are raised, which shows that testes are failing to produce the adequate amount of sperm for pregnancy to occur. Am I clear so far? So I would be telling all the options of the azoospermia. That is obstruction. Yeah, how do we say that? That there can be some tumor sitting in the testes and that is causing obstruction. Or the sperms, they are going the wrong way. Do you get my point, all of you? What am I saying all about? Yeah, retrograde ejaculation. Am I clear that how do you say that we are not having the adequate sperms outside? So there can be, all of you please be active in the chat box. I'm not getting any messages. I have this feeling that people are sleeping. I know Dr. Sabia is awake now. She has had her good sleep, but all of you please don't sleep during the session. We are going to take rest after the session, I promise. Okay, thank you. Thank you, Liana, my dear. Thank you, Harshaba. So then you're going to say that keeping your hormone levels in mind, it is a failure of the testes to produce the adequate sperms. Okay, so then you're going to move to the next, to the management plan. All right. So the female partner was fine. These were a few points which I wanted to add. It is basically a testicular failure, and I'm going to come to the management plan of each. So Liana always has a good communication. She is smooth. She knows that how to handle the role player. Though today the management went a little up and down because the topic was not prepared, but that's understandable. I'm going to give you a perfect management for each type of male subfertility just in a bit. One thing which I would like to say is that if the patient asks you somewhere in between, sorry, Liana, if I ask a question now, doctor, I have a request. You have told me about my report. If I come to you, or if Sarah comes to you, please don't share my report. Would that be okay? What would be your answer, Liana?
It's totally your decision, Mr. James, but I will encourage you to share with your partner regarding this, because it is both of you are having this fertility journey together.
First, ensure that yes, you're not going to tell until unless he wants to tell, right? So you say it's absolutely confidential. We are not going to discuss this report with anyone until unless you want to share. However, because the couple is required to have a mutual agreement on the treatment plan, I would like you to take her into your confidence and discuss with her so that we can counsel you together as a couple. We do have management options, Mr. James, and we can counsel you as a couple if you wish to. Would that be okay? All right. So this is how you're going to mold him, but at the same time ensure confidentiality. Well done, Liana. Thank you. So the history taking was fine. You did ask about the personal questions, about the frequency, about any issues regarding arousal or ejaculation, about the diabetes history, about the medical, family, surgical, drugs, social, mental, and the partner history as well, the examination. So these are certain things which need to be asked in the components of the infertility history in the male. The medical, the surgical, the fertility history is also very important. The sexual history, the medications, Liana did realize that, asking about the medication history when she was coming to the management plan. Assessing his main concerns and involving him in the process, ensure confidentiality. Always remember, if at all he's taking alcohol and smoking, that needs to be avoided. Today I was easy in putting up the semen analysis because I had put the interpretation of azoospermia. At times, they give you a value of the concentration as well. At times, they give you a value of progressive motility as well. At times, they give you a value of vitality as well. So you should be very sure that, you know, what are the interpretations as per the WHO, World Health Organization reference limits for the semen analysis. Please keep a note in exam, because you should be knowing what is oligozoospermia, what is asthenozoospermia, what is teratozoospermia. What is oligozoospermia? Levels less than, sperm concentration levels less than?
15 million.
Thank you very much. What is asthenozoospermia?
Abnormal
motility.
Thank you very much. What is teratozoospermia?
What?
Teratozoospermia.
Abnormal forms.
Abnormal forms.
Very well done. So less than 4 is going to be teratozoospermia. Less than 32 forward motility would be asthenozoospermia, and less than 15 per ml would be oligozoospermia. Because at times in structured discussion, you have to name this, or you should be knowing the diagnosis, that what is below that. Please keep a note, because we've got multiple stations in the recall for the male subfertility. Now, if the male subfertility comes in exam, the first thing is that history and examination has to be done. Semen analysis has to be interpreted correctly, and you have to ensure that you're going to repeat that in 12 weeks time if it's less than 15 and more than 5. If it comes as less than 5 into 10 raised to power 6, then it's severe abnormality, and we say that we are going to repeat the semen analysis as soon as possible in the next few days after the abstinence of the sex. Along with that, we are going to do your hormonal profile, the hormones like FSH, LH, testosterone, and the prolactin levels as well. Now, if it's an azoospermia, you can take the sample from the testes, and this is going to aid with the diagnosis whether the sperms are being produced or there's a problem with the tract. And it also gives the sperm, provides the sperm for the assisted reproduction in the laboratory as well. Now there are 4 situations which come in exam. Today, what we were discussing about was this third situation. If in exam the testosterone is low and increased FSH and increased LH is there, we say that this is the testes are failing to produce these sperms. The treatment option which we have is, number one, we are going to take the sample from the testes. If at all we get some healthy sperms for meet up with the partner's egg in the laboratory, and once the baby is formed, is going to be placed in your partner's womb and the pregnancy is established. However, I would like to discuss, Mr. James, that if we do not find healthy sperms, even after taking direct tissue sampling from the testes, that means that they are not being produced at all. In that situation, you have to consider the donor's sperm, which is going to be, again, the same process is going to be done. It's going to be a meetup of a donor's sperm with your partner's egg and would be placed inside the womb of your partner. So we call it as donor sperm IVF pregnancy. If at all it doesn't work, as a last resort, we always have an adoption to consider. Again, Liana, adoption is not to be forgotten, right? It is the last thing we always give it as an offering, a management plan in subfertility. Okay. Now in exam, if it's low FSH and low LH given and low testosterone, then it's hypogonadotrophic hypogonadism. Then you are going to give injections as a treatment option, please. In vitro fertilization is going to be one of the options, and adoption as a last resort. In exam, there can be a scenario in which they give you normal testosterone, the follicular stimulating hormone and luteinizing hormone are normal as well. If everything is normal, then please rule out the tract obstruction. In that case, surgically sperm retrieval is done, and then that sperm is being used with the partners, meet up in the laboratory, and then the pregnancy the baby once formed, the pregnancy is established by attaching that into the partner's womb, and IVF and adoption is the last resort. There can be a scenario in which karyotyping is a problem. So for that, you're going to refer to the geneticist, please. Depending upon the sperm count, you're going to decide for the ICSI, that is IVF, or donor sperm, and in the end, adoption. So today we were discussing about this, but the idea of making this is that you should be knowing about case number 1, 2, 3, and 4. All 4 can come in exam. Am I clear, friends, that how the male subfertility would be dealt with, starting from here, going down below, and different options according to the investigations provided to you all? Yes? Clear? Okay.
Yes.
So this was the scenario which we were discussing today. Okay, this was the scenario which we were discussing today. Thank you very much for all your male subfertility. Just go with this algorithm, and I'm sure things will be perfect. Introduction, agenda, information gathering, explain the diagnosis and the cause. Rule out all the causes. If the hormone levels they are raised, then go with the testicular failure. Evidence-based management plan, it should be there. Address our concerns, his concerns, mutually agreed plan, it should be. And please tell him about the follow-up. If at any point he's not comfortable sharing about his report, please ensure confidentiality as well. Thank you very much. Thank you. Any questions regarding male subfertility, please? Anywhere you people are stuck up in the station or you need to ask any question, I'm here to answer. Yes, please. Am I clear about the male subfertility? It happens, Liana, whenever you are a listener, lots of points that come into mind. I'm sure Dr. Sabia, Dr. Sujata, Harshiba, they all would agree. And once you are doing some station, it is always like that the points they tend to miss up. So I'm sure if you would have been at the listener end, you would have picked up LHFSH's range. But once you're doing a station, of course, I can understand that the hot seat nervousness is there. So it tends to happen that you tend to miss out. But I'm sure after this algorithm, you would be in a better position in managing male subfertility. Am I right? Am I right in hoping so?
Yes, I'm so nervous and I don't know what to say or think.
I totally understand. No problem. Again, I'm really grateful that you volunteered for a second station, my dear. I'm really grateful for taking the place for Girija today, because it was difficult for me to do the stations in the absence for so many of students today. I'm really grateful. Thank you very much, Liana. Okay.
Thank you,
all right.
One question.
Yes, please. Yes, please.
Should I offer or suggest him for other supplement to improve the sperm count, like antioxidant, zinc, and selenium?
Not evidence-based, and specifically in the testicular failure. But if he says that there is something like, we won't say that it's evidence-based, but as a tonic, it can be taken. But it can't be like a sole treatment which is going to have a success. Okay. So if you insist for that, it doesn't have any, the negative effect. But at the same time, as a sole treatment, we won't offer because it's not something which has an evidence of success.
Okay, how about if the patient have erectile dysfunction and want to try Viagra?
Yeah, again, you're going to say the same. If the patient wants to take it, it increases the circulation and the erection is the chances that yes, it is having a good strength in the erection. Again, we have got little evidence for that. It is being used. No, we can use that, but again, it's not evidence based.
Okay.
No, Dr. Subra, this patient doesn't need to refer to a neurologist.
For what reason? No physical abnormality in the examination, Dr. Sabia. In the fertility clinic, you can treat the couple, male and female both.
So we will refer him directly to the IVF.
You're already in the fertility clinic, so
we will refer this patient directly to the ICSI for or IVF there.
After ensuring that in the testicular biopsy, first step would be taking the testicular biopsy, and if some sperms are found, go with the ICSI, and if sperms are not found, then go with the donor sperm ICSI. Okay. Thank you very much. Any other question, please?
Yeah, how supposing the semen analysis is given as a result, do we have to confirm that whether the person followed abstinence and where it was collected? Do we confirm all that, or just
if it's a second report, Dr. Sujata, if it's a second report, then I would
second report, no need to.
Then I would not do that because it's a confirmatory. If it's a first report, I would just say that may I know that all the prerequisites and the counseling was done before this test in terms of abstinence was done before this sampling, and where actually the sampling was done. How much time did it take to reach to the laboratory? So then it's a valid question. Okay. But here lots of things were there. Here, why would I not suggest that, or I would not emphasize on this, because hormonal profile is supporting azoospermia.
Yes.
So otherwise, yes, for a first incidental test, Dr. Sujata, these are the valid questions which you're asking. Okay.
Sure.
Thank you.
And you said one tumor on the testis. I didn't understand that. I thought some obstruction, meaning like any injury to the vas, or
at times there's some mass in the testicular mass, some growth which causes obstruction.
Okay.
So that means that the sperms are being produced, however, they're not coming in the ejaculate.
Produced, but not.
Yeah.
But then the hormone level will be
normal. That's why what I said, that there can be certain reasons that in which sperms are not coming into the ejaculate or in the analysis. However, in your situation, as per the hormones level, it seems to be a failure of the testes, that they're not being produced. Okay?
Okay.
Yes, Dua, you had an unmute, my dear.
Yes, Dr. Seda, please, for as regard the hemoglobin A1C, we have to highlight this point.
We have to refer to the diabetic doctor for the treatment. That's it.
Okay, but it's not related to the azoospermia.
They can be. It can be. Diabetes has its relation, autoimmune problem, as premature ovarian failure, and the thyroid and the failure, testicular failure. All these can be because of some autoimmune destructions as well. But this patient is already 45. It can be a failure of the age as well. You know, the testes are tending to fail.
Okay, if Saul player asked what is the causes can be lead to that, we will mention all the causes of testicular failure, or we will just highlight the point that related to the case scenario here.
To the case scenario, because otherwise it would be a long list. The hormonal profile, you simply say that there can be like 3 points. I said that at times it is the sperm going the wrong way. At times there's some tumor sitting inside the testes, which can cause obstruction and blockade of the tract. So the sperms are not released. And at times it's not being produced. So in your condition, as per the hormonal profile, it seems that the testes have failed to produce the sperms. We call it as testicular failure. Okay. So basically 3 major problems are there.
Okay, thank you, Dr. Sabah.
Welcome, Dua. All right. So any other question regarding that? Okay, I've got one more station, but I had to do it with the Sarwat. So do we have Sarwat here? Did she join? Now I don't know whether she wants an exchange or Give suggestions, guys, what to do. Sarvat station. Do we have Sarvat here? No, not joined?
No, Sarvat not joined. If anyone agreed to do instead of Sarvat, I think it should be done. She's very busy. If Abhi, from my group, if Abir and Atia agree to do, or any other.
Dr. Atia, do you have the station in the last, the oncology? Dr. Atia, do you have oncology station in the end? Because that is Saturday, so Friday suits you. Because you won't be able to present on Saturday, right? Hello, Dr. Atia. I know multitasking going on. You must be in the kitchen. Dr. Atia. Atia's not here too? Okay. All right, so let's take then Sarvat station. I don't know, because if nobody's going to exchange, then Sarvat station's gonna be dropped in, which I don't want. So shall we do it in the next then? On the Saturday?
Yes, I think it can be done because.
Okay, then I'll do one station I'm writing down. Okay, I'm writing Dr. Sarvat's station. And what is the station? With oncology.
There's 2 stations not discussed yet, Dr. Isidra. Station
Sorry,
number.
come again?
There's 2 stations not discussed yet today.
Yes. Actually, yeah. The reason is that basically I wanted Divya to be here as well. And now I don't know, actually, see, if you people don't make an exchange, it's very easy for me that anybody can do that. But the only problem is that if somebody does that, then it's going to be a problem at their end, that they should be able to do that. All right, Harshaba, if you are ready, anybody can do Divya station. I don't know whether it's an exchange or not, because in the last, somebody go into the group, please, and tell me who are the participants in the last oncology.
Dr. Sindra, I'm not there in oncology, so
so then it won't be an exchange, right?
Yeah.
Actually, she didn't drop in a message for this, so I'm in a fix as well. I mean, it's easy for me to make it open, but actually then the station would not be being done.
We can do it with oncology if Dr. Sarvat can join us.
All right.
On that session.
We'll do that. Okay, we'll do that on oncology. I've written it here. Okay. So let's go with the oncology then. The oncology basic template, friends, is going to be a breaking bad news. Basically, you need to remember. Don't forget the breaking bad news ever, no matter it's a pre-malignant lesion or if it's a malignancy. So never forget that breaking bad news is something really very important, and empathy is being tested in that station. Never be blunt to a cancer patient, or even if it's a pre-malignant station as well. Introduction agenda. Ask about the complaints. If it's a problem with the urine, all these questions I've written. If it's a problem with the lump, if it's a problem with the cancer, always ask about any confusion, shortness of breath, upper tummy pain, indigestion, lump anywhere else in the body. The pain in the tummy, or since when is it? And do ask about the type of the pain, aggravating and relieving factors as well. About the menstrual cycle, if the complaints are there, and if it's pressure symptoms and swelling legs, feet, some sort of a visible veins, sickness, vomiting, shortness of breath. Then complete the gynae history, obstetric history, medical history, family history. I always stress upon the fact that family history is asked generally, that family history of concern. Generally, you ask in all the modules, but when we come to the oncology, we have to ensure and tell the examiner that clear-cut question, family history of cancer of the womb, neck of the womb, ovary, or breast. Okay, so clear-cut question should be there about family history of cancer of the womb, neck of the womb, ovary, or breast. Surgical history. Please ensure that you confirm drugs and allergy. Personal history, social support is very, very important in oncology station. Mental health and offering a support group is of vital importance in oncology station. Please begin your management in oncology as an ST5. Do not start managing cancer yourself. Please start with MDT, multidisciplinary team, and according to the cause. Address the patient's concern and then do a closure. All right. So the template goes same way. However, They're going to be a little more empathy being tested. Breaking bad news is mandatory, no matter it's VIN, no matter it's lichen sclerosis. Other group, they had a problem in the lichen sclerosis. They thought, ma'am, it's just a lichen sclerosis. Why to do a breaking bad news? All pre-malignant lesions, you have to break the bad news. Okay, you have to do a mild signposting for that, and a very solid signposting are required before a cancer station. All right. Any questions regarding the discussion? I'm going to put all the oncology topics. What is the date which we have decided? It was Saturday. Let me open the calendar. It was Saturday
27.
Yeah, okay. Saturday 27th, we are going to do oncology. I will post all the stations now in the study group and with the reading material as well. Would expect that tomorrow you people do all the revision of your sexual module, please, for 3 to 4 days. Sorry, the subfertility module, 2 to 3 days. Complete that, the remaining parts, complete your templates, and then come to the oncology as early as possible, so that you people have a very good grip on the speaking and empathy being tested in the oncology module. The more you're going to present good, of course, I have more chance of polishing you guys. Okay, so if you are at the basics, of course, my chance of improvement, making an improvement into the station is less as well. If you're more prepared, of course, I have more chance to polish you for those aspects which I need your strength to be in the exam. Any questions, please? I'm here to answer.
Dr. Sidra, it will be the last session?
Live session, yes, it would be the last session.
After that?
After that, I'll put a schedule for the book, whatever book you would like to decide. And then in the mini group, you people would start the group practice for the book. So I would request you all to do like 15 days, the bigger books, and I think 5 to 7 days for Lisa. So you have to complete in the next 1 to 2 months. Meanwhile, the date would also be announced. So then according to that, you're going to start your practice. In the mini group, the books would be started. And these all recordings would be with you. What other batches had been doing was that they picked up one module from the back and started revising its templates and revising those stations side by side, because even in the January exam, the students which had this exam, it was all the repeat. All 14 stations were the repeat stations. So I want that repeat stations, there should not be any ambiguity. There should not be any confusion. The flow should be perfect. And as I was saying that I was doing the bacterial vaginosis station, and believe me, the role player, it was like 1.5 to 2 minutes left. And I was talking to myself during the exam. It was my last 14th station of the circuit. And I was talking to myself, oh my God, the role player has forgotten. It has to be yogurt. She has to ask for yogurt. Why is she not asking? I know the station. And the last 1 minute, she said, doctor, can I use yogurt? I said, yes, I knew that you're going to ask it. I'm ready with the answer. This is what I want from your side as well. That if it's a repeat station, you should be knowing that what's going to be up and what you are going to answer. Okay. So yes, Abir, you had raise your hand, please. I'm here for
Assalamu alaikum. How are you, Dr. Sidra?
I'm good. How's your health, Abir?
Alhamdulillah, fine.
That's great to know.
Sidra, I asked you before, how can I read the box for part 3? You say, remember me.
Yes. Yeah. Thank you very much. Abir, when it comes to the any book, when you open up any station, you have to make your template and attach at its back introduction, agenda, information gathering. Make your questions of the information gathering and management outline the way I make algorithms for you guys. So you stick on that, your station is solved. That's it. If any lines you think you need for it, you have in the patient information leaflet, write those lines of explanation on that. If you are stuck up somewhere, ask me, I'm going to provide you lines. But every station, if you see my Oxford, it is all solved. One page is the station. At the back, I've solved that station. Second station, at the back, I've solved that station. So you solve it by making outlines so that in the last 1 month, you just revise your outlines.
Dr. Sidra, how long are the 4 books going to take to complete?
See, the Oxford has got 80 stations. So it would take around, but many of the topics are repeated as well. I mean, you take out oncology and subfertility, almost all topic templates you've got here, but little change in the role player instructions, but the outline of the management would be the same. So I would say that 1 month for the Oxford, maybe 10 days for Tony, 5 days for Lisa, and for Sir Kunje's book, it's 2 circuits there. students are doing around, they've distributed what they've done is that they've distributed in the mini groups. So they're making templates separately. So the entire book was completed in 1 week time. So I would also do that same for you guys so that your stations get completed. For example, if it's Oxford, so first 20 stations template and the solved stations are being done by group A, next 20 by B, next 20 by C, and next 20 by D. So you'll get everything to prepare and your 20 would be prepared by others. So in that way, everything would be prepared. This is how previous batches were doing as a group. So they had, they didn't have to take time out for everything. They took printouts of the 60 stations which were done by others and 20 by them. So that was easier, no?
Yeah, we should do that.
Yeah, so this is what the previous batches would be doing. There are around 150 students since April in different mini groups. So they're doing in this way. 2 have completed all the books and the rest they're doing. And I've got templates for almost all the books sorted as well. I'm going to help you guys whenever you're going to be, stuck up with the preparation. The books are almost all books are sorted, okay?
Okay. Thank you, Dr. Sidra.
Thank you very much, Rishabha. Thank you. All right. Any other question, please?
Dr. Sidra, I think we have still 2 pending stations from the previous classes.
I think 1 is done. Dr. Bindu's, right, Dua?
I think still 2 for Dahlia, but actually I don't know what is Dahlia's situation.
Dahlia, yeah, she messaged me that she would not be able to take the exam. And that's why today also I just skipped her station from this because she actually wanted to be a listener. So yeah, so she's no more.
I think there's still 2 pending stations from the previous modules.
So please let me know whatever is pending. Okay, I'll provide, because if Dahlia is not presenting, I'll provide you with the station on the Google Drive. Okay, so the recording.
At least the algorithm. We will take the algorithm. Yeah.
I'll tell you the solved one from other batch, because if Dahlia has shifted to the listener, so that station I'm going to provide to you guys because it's an exam station. Just make a note of that and just message me so that I can give you that. Okay.
Okay, Dr. Sidra.
Thank you very much, Dua. Thank you. All right, so take very good care.
One more question, Dr.
Sure,
Sidra.
Dr. Siddhartha, please.
Yeah, when we are doing the books, you will not listen to us. We will be just discussing in the groups.
See, the live session won't be there, but anything if you have to ask, you're always welcome to send a voice note whenever you are stuck up.
Okay.
Yeah.
Okay. Sure.
All right. Okay, thank you very much. Any other question, please? Any other question? No? All right. Take very good care of yourself, friends. So see you guys on leaving one Saturday and skipping one Saturday into the next Saturday. We're going to be together again for the oncology session. I would request all of you to have a good presentation so that we feel that once we started our journey where we were and today, where are we standing? Now you know everything. The only thing is that we require practice together. I love you all. Take very good care of yourself. Remember in prayer. See you guys soon. Please be active in the mini group and stay in touch. Bye-bye from my side. Fi amanillah. Bye-bye. Thank you.